All right. Good morning, everyone. Welcome to the inaugural 2022 Southwestern Sydney Local Health District Oral Health Symposium, which is being conducted as part of the Health and Beyond Research Innovation Showcase. My name is Ajesh George, and I'll be chairing the session. Our theme today is Making Oral Health Everyone's Business, and is in celebration of World Oral Health Day, which was on Sunday, March 20th. Today's symposium is being led by the Centre for Oral Health Outcomes, or Research Translation, or as we know it as COHORT, which is a joint collaboration between Western Sydney University School of Nursing and Midwifery and Southwestern Sydney LHD Oral Health Services. Now, before proceeding with the symposium, I'd like to invite Caitlin May Franks, who is an Aboriginal dental assistant in Southwestern Sydney, to say the acknowledgement of country. Welcome, Caitlin.
Thank you, Ajesh. My name's Caitlin. As Dr. Ajesh said, I'm an Aboriginal dental assistant in Southwestern Sydney Local Health District. And I'd just like to welcome everyone to this meeting on which this land takes place today, and just acknowledge the elders, both past and present, of which this meeting takes place. Thank you.
Thank you, Caitlin. All right, so now I'd like to just kick off the symposium with a few words around integrated oral health care. So first, a bit of background about myself. So I'm the director of COHORT. I'm also the professor of interprofessional oral health at Western Sydney University. So why is integrated oral health care important? Well, if you look at the Australian population, we see that 40% of children, 30% of adults have untreated dental decay, and around a quarter of adults have severe gum disease. Further, dental conditions are the third highest cause of acute, potentially preventable hospitalizations. These issues are exacerbated in Aboriginal and Torres Strait Islander populations, non-English speaking and low socioeconomic groups, as well as those with special needs and chronic illness. Adding to the fact is that we know that poor oral health is linked to various systemic diseases like cardiovascular disease, diabetes, aspiration pneumonia, and is linked to adverse pregnancy outcomes as well. In addition, it has a negative impact on quality of life, particularly in populations that are aged, in palliative care, or have disability. So it's now well established that oral health is an integral part of general health, and is often referred to as the fifth pillar of wellness, along with diet and nutrition, physical activity, stress management, tobacco cessation, and sleep. However, there are key barriers to oral health, particularly in Australia. These include high cost of dental care because of no universal dental coverage in Australia. In 2017, Australians spent $10.2 billion on dental services, with an average household running a bill of around $30 a month. As a result of this overly expensive dental care, nearly 2 million people in 2017 didn't get the treatment they needed, with low-income households much more heavily affected. The other issue is the long waiting list in eligible populations to access free public dental service in Australia. Now, these issues are not surprising to many of you. However, there are two other barriers that impact or deter promoting oral health, and these are the general lack of awareness among the community about the importance of oral health for general health, and the limited emphasis being placed on oral health by the broader health workforce. Now, the first two barriers I highlighted are hard to address because of funding constraints and will always be a challenge. However, the last two factors are things that we could address through various targeted strategies, particularly through integrated oral health care and building the capacity and capability of the broader health workforce to promote oral health. There's general consensus now that the dental profession cannot alone tackle the oral health inequalities and dental diseases in the community. So last year, the World Health Assembly approved a historic resolution on oral health, acknowledging the need to shift from the traditional curative approach towards a preventative approach within the primary healthcare system, involving other health professionals. Now, these sentiments are reflected in the Australia's National Oral Health Plan and many state oral health strategic plans, which have been further highlighted due to the COVID-19 pandemic. Now, we knew very earlier on that this change in approach to oral healthcare was needed, particularly in southwestern Sydney, due to the unique demographic characteristics of our population. So in 2015, we established COHORT, Australia's first interprofessional oral health research centre. As I said earlier, through a unique collaboration between nursing and midwifery at WSU and oral health services in southwestern Sydney. It's been an amazing journey over the last 6 years, trying to put the mouth back into the body and make oral health everyone's business. Today's symposium will provide you a snapshot of the various research and QI projects that have been undertaken in this area across the lifespan. We really wanted to showcase the engagement that has happened over the years with the health service. So you'll see a number of short videos from clinicians. We also wanted to highlight QI projects led by clinicians, so we have pre-recorded their presentations due to their time constraints, particularly for the oral health services because they've just finished accreditation and they're opening up their new oral health clinic in Campbelltown Hospital. We'll have 4 sessions today, focusing on co-designing models of care, priority populations, improving clinical outcomes, and research impact. We will then end with a presentation around consumer and stakeholder involvement. So on that note, I'd like to thank you all for joining today's symposium and hope you enjoy all the presentations. Thank you. So I'd now like to share a few words from Associate Professor Ravi Srinivas, who's the Director of Southwestern Sydney LHD Oral Health Services. And unfortunately, Ravi could not attend in person, but he has shared a pre-recorded message.
Good morning, everyone, and welcome to the Southwestern Sydney Local Health District Oral Health Research Symposium. This research symposium is a highlight and a culmination of a lot of work which has happened between the University of Western Sydney and Southwestern Sydney Local Health District. More specifically, to the School of Nursing and Midwifery at Western Sydney University and the Oral Health Service of the district. The research collaboration really looks at supporting the district in playing a key role in population oral health research in the state. It has, over the many years, built up a high-quality evidence base which has informed new models of oral health care. The collaboration has also resulted in more than 60 peer-reviewed publications since 2015, and also produced a lot of oral health promotional resources which have actually been endorsed by our peers at New South Wales Health and other key stakeholders. It was also pleasing to note that this work's been acknowledged throughout the many years of its existence through quality awards across various categories, such as keeping people healthy, excellence in provision of care and services to Aboriginal clients, collaboration working as a team, and also it was a finalist in the New South Wales Health Award. Research is a very important part of our operations, and research provides support and mentorship for oral health staff to be engaged in research, quality improvement projects, publications, and conference presentations. This is really important because we want to make sure that clinical practice is underpinned by evidence-based and evidence-based research. It is important to note that the research collaboration is significant as it's being done through an interdisciplinary cross-health professional engagement to further population oral health research. This will truly make it a bench to chair side effort. So welcome once again, and I hope you enjoy today's symposium. Thank you.
Okay, now I'd like to call on Professor Les Bouquet, the Research Director of Southwestern Sydney LHD and the Director of the Ingham Institute for Applied Medical Research, to say a few words. Welcome, Les.
Thank you very much, Ajesh. Professor Ajesh George, Professor Ravi Srinivas. I'm very privileged and very happy to say a few words, and I'd like to welcome everyone who has joined this very, very important webinar. And in particular, can I join you all in acknowledging Professor Erin Hartnett, who's going to join us from New York. You're always welcome to join us, Professor Hartnett, especially at a time when we're all going through some difficulties with COVID and with other international issues. So thank you for joining us. Oral health is the genesis of well-being. It's as simple as that. For far too long, we've regarded oral health as dentistry. It's not just dentistry. It is the genesis and the continuum of well-being for all animals, including humans. What goes into our mouths, what stays into our mouths, what lives into our mouths, and what comes out of our mouths is very, very important. And when I say what comes out of our mouths, I'm not just referring to the various products that come out of our mouths. It's the words that come out of our mouths are equally important. And for far too long, we have considered oral health as a unidisciplinary issue, but it's not. It's a multidisciplinary issue. It's a family issue. It's an LHD issue. It's a statewide issue. It's a national issue, and it's an international issue. And I'm glad that it's finally achieved that recognition as a world health issue. And so as a research director and as a surgeon who's intimately involved with gastrointestinal, in particular with colonic cancer, I'm so pleased to see that oral health has become a principal pillar of health across the world. I'm here to learn. I'm here to congratulate you on bringing so many disciplines, as it should be, a multidisciplinary issue, to the foreground. And I congratulate you on the research work and the outstanding clinical work that you bring to our district. So thank you for inviting me, and I look forward to hearing the outcome of this webinar. Thank you again.
Thank you, Les, for those kind words. So our next activity is really an icebreaker activity, and we're going to try and see whether it will go without any hiccups. I'm going to hand over to the cohort staff, which will be led by Tiffany Patterson-Nori to go through the events, while I try and contact and make sure that Erin is being able to connect us from New York. So over to you, Tiffany. Thank you.
Hi, everyone. Thank you, Ajesh, for handing over. So we're just going to start with an icebreaker activity to really try and get to know what's happening with our audience and to get to know who you are and just to understand what is the nature of oral health and who's working in it and who wants to be part of it in oral health research. So if I just direct you for the first question of the icebreaker activity, we'll be looking to have your answers be dropped into the chat function, which is located at the bottom of your screen. So not the Q&A, just into the chat function to respond to this first question. So if you would please like to let us know, what is your discipline? So what do you belong to? And I can see a lot of you are already starting to post some of your answers in there. So let us know what you belong to. I personally am a dietitian, so I belong to allied health, and I'm working in oral health research at the moment. Oh, look, we can see we've got some people from dental, we've got nursing, we've got other, planning, oral health coming through, more oral health. Okay, so we've got a lot of people from oral health and dental health background. Got some more speech pathology. Welcome to Jenny from speech pathology. Wonderful. Anyone else? Am I the only allied health representative there other than Jenny? Oh, we got another allied health as well. Got more dental coming in. All right, wonderful. Lovely to meet all of you and lovely to see all of you guys here and participating. So we've got a big audience full of people from oral health and dental, nursing, some allied health, and a couple of people from other. So welcome to everybody to today's symposium. If we'd like to move on to the next activity. All right, so these two, we're going to have a couple of questions. So in order to access this, you can either go to www.menti.com or you can use your mobile phone camera to scan the QR code and you'll be taken through to the Menti website where you'll be prompted to ask 2 questions. So I'm going to jump on and do this with you guys so I can see what's happening as well. So the first question is, do you think oral health is relevant to your clinical practice? And we'll start displaying the results from your questions. They'll be streaming live and they'll pop up on the screen in just a moment when we get it connected. So please use the QR code to scan through or type in www.menti.com and we'll get the code. Yes, I can. Thank you, Leonie. I'll get the code up for you guys. Ariana, are you able to confirm what the code is for Menti, please?
Yeah, the code is up there on the top. 4942.
Yeah, I'll just pop it in the chat. So for anyone else who's looking for it, the code is 49425693. No worries. Anybody else struggling to get onto Menti or having any issues? You can use your phone to scan the QR code. All right, so we've got a couple of people that have jumped on and answered. So you can see the answers are updating live.
So obviously it would be relevant to the dental guys that have joined, but really interested in the guys, the non-dental attendees today. So that we see one not unsure. So might give you guys a few more seconds to. It's great to see that overall everyone feels that it is relevant to their clinical practice.
I think that might be everybody. Do you think?
Yep, someone's put a comment.
Yeah. Okay, so we've got Teresa saying, thanks. Whilst not a clinician, I work for ACHSI and we have oral health standards. Teresa, can you confirm what ACHSI is for those of us that don't know, including myself?
While Teresa's writing that, John, maybe you can move to the next question.
Yeah, definitely.
Oh yeah, there we are. Healthcare standards.
So what challenges do you face with promoting oral health in your practice? You would have seen on your Mentimeter, your questions would have updated. So if you can just pop in a couple of words into some of the boxes and just let us know what challenges do you experience when you're promoting oral health in your practice? And then we'll see them pop up as a cloud on the live screen. Thanks. So Teresa has just answered our question as well. ACHSI stands for the Australian Healthcare Standards International. And so they have oral health standards that they're working on as well. So we've got some words popping up on the screen. So we're seeing time constraints, prioritization, engagement, standard uptake, standards, staff and the numbers, clinical demand. These are some great challenges. If you've got any more, please jump onto Menti, www.menti.com, and the code is pictured at the top of the screen, 492425693, and just drop in some of the challenges that you experience in promoting oral health in your practice.
So for those of you who don't use this, obviously the most prominent words are the ones that are mostly input. So you can see right in the middle is knowledge and compliance and engagement, which is great. And that's some of the aspects that you will be hearing today through the presentations. So I'm glad that the audience is actually validating some of the concerns we've encountered in this integrated oral health and interdisciplinary oral health care. So please continue putting your comments in. That's really good. Someone's mentioned health in aged care. Yes, that's obviously that came up in the Royal Commission as well. That is an ongoing problem, as well as in the disability sector. We've got mental health as well there of patients. And we actually have a presentation in that space today.
Similarly on resources as well.
Yes, excellent. We're actually touching on that as well.
Stuffing.
Yeah. All right. I think that's great. So compliance, knowledge, resources, engagement seems to be the top 4 based on our audience, which are all very relevant. So thank you. I'm glad that we're all on the same plate. And firstly, most of you agree that it is relevant to your clinical practice, and you've cited some of the common challenges that the non-dental workforce faces in this space. Okay, I think we will then move on. All right, thank you so much, Tiffany,
No worries.
for that. All right, now I'd like to invite our keynote speaker, Associate Professor Erin Hartnett, all the way from New York, where it is, I think, 7 p.m. yesterday. So Dr. Hartnett is a pediatric nurse practitioner and a former program director for New York University, Rory Mayers College of Nursing Oral Health Programs. There are 2 programs that she was involved with, the Oral Health Nursing Education Practice and Teaching Oral Systemic Health. Dr. Hartnett has developed a national interprofessional oral health nursing curriculum and has coordinated many oral health interprofessional experiences with NYU medical, nursing, and dental schools. She has developed oral health education programs for the National League of Nursing and the Nurse Family Partnership, and has widely published in this area. She has also received numerous awards over the years, including the New York Times Nurse Innovator Award and the NYU Medical Center Advanced Practice Award. More recently, Dr. Hartnett has received the 2017 Georgetown University Outstanding Alumni Award for work in interprofessional education and the 2019 Edge Runner Award from the American Academy of Nursing. So like we mentioned earlier during Erin's presentation, if you have any questions, please post them in the Q&A function. So thank you and welcome, Erin.
Oh, thank you so much. Good morning from New York. I really would like to be there, but I want to thank Ashish for inviting me. And I'm very, very honored to be a part of your oral health symposium today. Next slide, please. So I'd really like to discuss the need for oral health across the whole lifespan, and also just demonstrate some of the strategies that we've used to implement oral health into both our nursing education and practice throughout the whole lifespan. Next slide, please. So I'd like to start with oral health in pregnancy, because during pregnancy, oral health can affect not only the pregnant person, but also the child. So the oral health cavity is particularly susceptible to hormonal changes during pregnancy, and this increases the likelihood of having an oral health problem during pregnancy. Next slide, please. So as you can see, there are significant oral health problems in pregnancy. If 76% of pregnant women complained about oral health problems, only half of them actually went to the dentist. So despite over a decade of studies emphasizing the need for oral health during pregnancy, access to dental care during pregnancy is very limited. And this reflects a need for oral health anticipatory guidance, oral health literacy, and increasing access to dental care in this population. Next slide, please. So what we've done with our students is this prenatal program. I'd like to just play a few minutes of a video that we made about the program. So this program, we combine our nurse practitioner and our dental students and our midwifery students, and they learn from each other. The dental students then learn a lot about pregnancy. The nurse practitioner and midwifery students learn about oral care. They screen all the prenatal women, and then as you can see, they can go from Bellevue right over to the College of Dentistry to the clinic there for any referrals that they need. Next slide. So it's been a very successful program. Another program we do with, this is for nurses in practice. This is home care nurses. It's the Nurse Family Partnership. It's a national home visiting program where a nurse is assigned to an at-risk first-time mother, and she visits with the mother all during the pregnancy and for the first 2 years of the baby, and providing mainly education and support. So we educated a small group of these home visiting nurses in Miami about what to teach the moms about caring for their own oral health and the babies. And we found this small educational program really made a big change, both in the knowledge that the moms had and their behaviors. And at the end of the program, the moms had been brushing the children's teeth up to twice a day, up to 82% of them, and they knew the information they needed. And we found that when the children graduated from the program, they had no white or brown spots on their teeth. So right now we have implemented this same program in a nurse home visitor program in Brooklyn. And this is called Public Health Solutions. And it's a New York City not-for-profit that strives to reduce health inequities in New York City by providing direct service programs. So we've educated the home visiting nurses there, and we'll be doing the follow-ups to see how well it works. So I'm hoping for the same results here. Next slide, please. So we also have lots of oral health programs for children and adolescents. The major socio-behavioral risk factors for the prevalence of dental caries in children and adolescents is related to their physical, environmental, behavioral, and lifestyle factors. The social determinants of health contribute to the oral health disparities, the poor nutrition, insufficient fluoride intake, poor feeding practices, poor oral hygiene, and the limited availability and accessibility of oral health services. Next slide, please. So early childhood caries are a major pediatric health problem. The most common infectious disease of child, 5 times more common than asthma. And this also occurs more often in lower socioeconomic groups and minorities. Next slide, please. So what we've done with our students is we have a group of students, a team of students with a medical student, a dental student, and a nurse practitioner or midwifery student. And they work together in the pediatric dental clinic at Bellevue. And they work with the dental resident, and they're learning how to do an oral exam and fluoride varnish, and then they work together to make a plan for the patient. Next slide, please. We also have a program where our students go out together, dental and nursing students, to the Head Starts. Head Starts are like a preschool for the underserved, and they do oral exams, fluoride varnish. The nursing students help the dental students learn about growth and development, and the nurse or nurse practitioner students learns to do an oral exam and fluoride varnish. So they work together and learn from each other. Next slide, please. In practice, we have a dental resident integrated into the care in our pediatric oncology center. And the dental resident is assigned on a rotating basis, and they see all of the patients on chemotherapy. This is an outpatient unit, but they also cover the inpatient unit. And all of the children get an oral exam and fluoride varnish every 3 months. Next slide, please. We also have an interprofessional mucositis oversight team where all of the different professions involved in cancer patients, and as well as pediatric and adult, work together for patients who are at risk for mucositis. Next slide, please. Now, when it comes to adolescents, there's an increase in dental caries at this age, and it's often related to their lifestyle factors, because often they don't have good nutrition and they have a lot of either sugary foods or sugary drinks. Adolescents are also at risk for sports injuries to their teeth. But one of the main problems and the main risk is HPV, which is the most common sexually transmitted disease and can cause cancer not only of the genitals, but the oral cavity. Next slide, please. So preventing cancer is a lot easier than treating it. Early prevention works best. This vaccine produces better immunity to fight infection when given at a younger age and given before the first sexual contact. Yet in 2018, our data showed that only half of the teens had actually received the vaccine. And studies show that it's the quality of the healthcare provider's recommendation that is the strongest predictor of whether the parent allows the child to get the vaccine. 45% of parents who initially refused the vaccine went on to accept it after they received more information from their healthcare provider. So we're really strongly educating our students to make sure that adolescents and their parents know about this vaccine and call it an anti-cancer vaccine. And it's the only vaccine which can really prevent cancer. So we are really trying to promote this through a lot of educational materials and presentations. Next slide, please. So adults of all ages are affected by poor oral health, particularly when they have one or more acute or chronic illnesses. There's a higher prevalence of these conditions linked to the social determinants of health, where there's a greater burden of oral disease and lack of access. Addressing these disparities by integrating oral health into primary care and acute care are essential to addressing the oral health inequities. Next slide, please. So a large majority of our adult patients seen in primary care actually have chronic disease. Many of these chronic diseases have an oral health component: diabetes, cancer, cardiovascular disease, respiratory conditions. These are just among the few. And then if you add obesity, poor nutrition, and sedentary lifestyles, this further complicates the situation. Next slide, please. So for our students, we have run this program for I think it's 9 years now, where we combine our students together in the simulation lab with a standardized patient. Standardized patient is supposed to have periodontal disease and diabetes, but the students have to figure that out. They work together taking a history, and then the dental student teaches the medical and nurse practitioner or midwifery student how to do an oral exam. They all practice the oral exam. And then they work together, they sit down in a case study discussion room and make a plan for the patient. So this has been a very successful program too in the simulation lab. And during COVID, we've been able to do this all on video remotely. Next slide, please. We also have another simulation where we put dental students and nurse practitioner students together in the sim lab with a patient who has Parkinson's disease and Lewy body dementia. And the idea is for them to really learn how hard it is for a patient who has no motor control or can't remember how to brush or when to brush their teeth or care for their mouth. And they have to work together to make a plan for this simulated patient. Next slide, please. A new program that we started is with GOMO Health. Now, cancer is really a serious problem that has many oral health complications impacting the quality of life. The oral health environment is subject to a wide range of changes during cancer therapy, including immunosuppression, salivary hypofunction, mucosal ulceration, and as a result, cancer patients are at a high risk for oral infection, especially during and also after treatment. So GOMO Health is an oncology digital therapeutic, which a lot of our cancer centers use, and it sends patients questions and gets real-time data on how they're doing during, after their treatments. And the patients respond to these questions, and depending on their answers, whether they get referred to a nurse for education, for support, or for an actual visit and referral. So we worked with them to integrate oral health into their platform, and we developed all different oral health questions related to cancer that the patients would be sent. And this so far has been working very, very well and very successful too. And it identifies a lot of oral health problems that were being missed before. Next slide, please. So in acute care, we find oral health is often very much neglected, especially during COVID, when so many people were in the hospital. There just wasn't time for a lot of oral health care. Next slide, please. So I'm sure you're all aware of hospital-acquired pneumonia, and there's two different types. There's the one that you get if you've been on the ventilator, and this is the one that's gotten all of the studies done and all of the protocols for it. But one that's even more common is non-ventilator associated pneumonia. And this can occur in any patient in the hospital, any age, any condition, and they develop pneumonia from being in the hospital. Now, both of these pneumonias have increased morbidity, mortality, length of stay, and cost. So we've been working on the non-ventilator associated pneumonia. Both of these are related to oral health too. Next slide, please. So we're working with the Veterans Health Administration, and this is a program called HAPPEN. It's Hospital-Acquired Pneumonia Prevention by Engaging Nurses. This program was developed by a nurse on a pilot unit, just one unit, and she developed a program where she would teach all of the nurses and nursing assistants on the importance of oral health and when to give oral health depending on the patient's needs. And she developed this protocol. Well, it was so successful that in decreasing hospital-acquired pneumonia, non-ventilator, and decreasing cost and length of stay, that the VA is now implementing it in 155 hospitals across the nation. So we were asked to join as members of their board to actually get this program out in the public and make sure that other places and other hospitals besides the Veterans Administration would take it up. So ours is called NOHAP. This is the National Organization for Non-Ventilator Acquired Pneumonia. And with this program, what we've recently done is we're making a program on the National League for Nursing website all about this program and how nurses can implement it in their hospital without being in the VA. And it's going up on their website pretty soon. And then we'll be reaching like 40,000 nurses right on that website. So next slide, please. And this is just a pictorial of how what the protocol is. And it's just that each patient, depending on their need, whether they're self-care to all the way to dependent care, they have certain oral health protocols that go along with their level of need. And in addition, they have to have their head of their bed elevated. They have to get suctioned at certain times, and as well as being given education and on oral health and nutrition. Next slide, please. And at NYU, all the patients who go to surgery, they all have to brush their teeth before they go to surgery. And this is also to prevent non-ventilator acquired pneumonia. Next slide, please. So when it comes to COVID, we really, I think, I don't know if it happened in Australia too, but for us during the first wave of COVID, there was a very large impact on oral health. Well, first, all of our student clinicals were discontinued, so we couldn't do a lot of those programs. All of our dental services were closed down for about 4 months. This increased the burden on the hospital ERs. So many people lost their employment. They also lost their dental insurance. And then the World Health Organization advised that non-urgent oral health care like checkups, cleaning, and prevention be delayed. So there were many, many issues involving oral health, and populations that were disproportionately affected by COVID, they're the same populations that are higher risk for oral diseases and experience oral health disparities and lack of access. So it just compounded a lot of those problems. So what we did was we made an oral health resource kit. We sent it out to all of the national nursing organizations and clinical practice organizations to include COVID and oral health. We disseminated it to all of our members, put it on our website, and then we also developed an oral care case study with COVID, called COVID in the Family. And so our resource kits are all on our website. luckily, dental care is back. And there's a lot of catch up being done now. So next slide, please. So when it comes to behavioral health, we find a lot of people forget about oral health and behavioral health. Stress affects the immune system, the sleep, the pattern of personal hygiene, and all of that affects oral health. Stress can affect your oral health in a number of ways, and damaging your teeth, your gums. People with psychological disorders are often at risk for many oral health problems due to the side effects of medication and the neglect of their oral health. So early detection, prevention, and treatment are very important in dealing with any patients with behavioral health problems. Next slide, please. This is just a list of some of the problems we see with depression. There's often a lot of substance abuse and self-neglect. In bipolar disorder, there can be a lot of overbrushing. In eating disorders, there can be vomiting, causing some tooth erosion. There is often bruxism. Also, medications such as antipsychotics, antidepressants, and mood stabilizers cause a lot of xerostomia. Next slide, please. When it comes to older adults, we really find that this is also a problem. Many of our older adults don't have any dental insurance because it's not included in Medicare. And the older population have a lot of retained teeth. It used to be that they had lost their teeth and they would have dentures, but now most of them have retained their teeth and they require a lot of repairs. So for our older adults, there's many issues that interfere with them getting the care that they need. Chronic illnesses, the medications they're on, transportation to care. But they all still need to have their teeth cared for. They have need for pleasure, for smile, for kisses, for laughter, and to feel good about their mouths. Next slide, please. So we have a program where we have our students going to the senior centers in the Bronx, and they do educational programs for the seniors, not only for the seniors, but the volunteers, the case managers, and the home care people too. So this has been a really nice program. We have dental students with nurse practitioner students and RN students as well. Next slide, please. And we've given them education not only on oral health, but oral health and diabetes and nutrition and oral health. Next slide, please. We also have a geriatric webinar series up on our website that anyone is welcome to view. Next slide, please. And then we work with our palliative care nurse practitioners for oral health at the end of life to be sure that they're integrating that, because the mouth is really integral to the quality of life. And at the end of life, people, you want to be sure they have nutrition and dignity and comfort, and that they can communicate and socialize and be intimate with their loved ones and feel confident that their mouth is fresh when they are saying goodbye to their loved ones. So next slide, please. We just have a small table where we have our nurse practitioners be sure that they're keeping oral care, make sure that oral care is done for their hospice and palliative care patients. Next slide, please. We did a survey in 2018 of all our nurse practitioner programs nationally. Although we only got a 50% response rate, we felt like we were doing okay. We were doing better at getting oral health into the curriculum there. Next slide, please. We tried to run as many development workshops with the interprofessional faculty, not only to make sure they know about oral health, but that they learn to work with each other, and they just learn to know who each other is. And that is really most of the job, is just getting people together. And then they're happy to do programs together once they know each other. Next slide, please. Before COVID, we used to go to conferences, all the different professional conferences, and run oral health workshops there. Next slide, please. And then we have a lot of resources on our website. A lot of the things I've talked about, you can just go to onep.org and find it on the website. Next slide. We have Smiles for Life. This is a free online curriculum, which has 8 different programs that you can go on and learn about oral health in each different age group. Next slide. This is a program we have on the National League for Nursing website for seniors, all about oral health. And this is for faculty to go to and to learn about how to teach oral health for seniors. Next slide, please. We also have the same type of program on the NLN website for pediatrics. Next slide. We have learning modules for our preceptors, because we found we were sending students out with preceptors, and the preceptors didn't know anything about oral health because they had graduated before oral health was part of the curriculum. So we have all of our preceptors have to do these modules, and oral health is one of the modules. Next slide. These are just some of the articles we've been writing. During COVID, we wrote a lot of articles. I think it was published like 8 articles. Next slide, please. These are some fact sheets that are on our website you can download about oral health and HPV, diabetes, or older adults. Next slide, please. And then this is a curriculum that I developed for, this is for the graduate programs. And the next slide is for the undergraduate programs. So it gives you, it's all based on learning competencies, and there's all kinds of activities and resources for faculty to use to teach oral health in either the graduate programs or the undergraduates. So feel free, they're on the website. Anybody can take anything they want to use from this. Next slide. We have a Jeopardy game that we play with the students, an oral health Jeopardy game. Next slide. This is Oral in the Family, where we have a family with, everybody has a different oral health problem, and we work with the students with this. That's on our website. And then we have COVID in the Family too. Next slide. And this is our last slide. We have all kinds of social media. We have Facebook, Twitter, we have a blog, we have a newsletter. So we're trying to get the word out to whoever will listen. So I want to thank you very much for listening, and if you have any questions.
Thank you, Erin, for that wonderful presentation and really reinforcing the importance of integrating oral health across the lifespan. I'm sure everyone can agree, you guys are doing some amazing work out there, really pushing the boundaries in this space. I mean, for you to have an national oral health nursing curriculum is truly amazing. I think we in Australia have struggled to get the nursing workforce to I guess, embrace oral health, and you guys are going leaps and bounds there. I might just, what I didn't mention at the start when I introduced Erin is we first connected with Erin in 2019, and we started learning about the wonderful work she's doing there at NYU, and we quickly got her an adjunct position at Western Sydney University because we wanted to learn from her. So she's an adjunct associate professor in the School of Nursing and Midwifery, and since then she's played a key role in trying to integrate oral health into the undergraduate nursing curriculum. We have a PhD student, Jacqueline Roger, who's doing that, and so Erin's been playing a key role in that, and we've already integrated into a few of the modules there. So We have probably around 3 or 4 minutes for questions. I can see 2 questions, 1 question in the Q&A. Erin, I know it's getting late. Did you have around 5 minutes to spare just for a few questions?
Yeah, of course.
Great.
I'm sorry if I ran over.
No, that's perfectly fine. So the first question is, any role for topical antibiotics in preventing recurrence of caries? Not sure if you...
That's something I'm not familiar with at all. Is that something you do?
Yeah, I think so. Sure, Jay. We might get back to Jay about it, but there's some few questions in the queue in the chat room. I think someone wanted topical vancomycin, basically.
Oh, I'm sorry, I'm not familiar at all with that.
That's okay. I think few people commented if we could the links to the webinars, they're on your website, Erin?
Yeah, everything's on the website.
Right. Okay. Please ask any more questions. Erin, I had a question. One of the things that when we did our icebreaker activity, a key theme came up was compliance. And so, do you have any, suggestions, like in the hospital system? What are the strategies to improve compliance? And I guess linked to that is really, how did you involve policymakers to really push this agenda in the US?
Yeah, I think the best example of the compliance is with the VA, where they really work to get it into their system. And, it's just part of the whole program, and the nurses have to document it. But it took showing that it made a difference in the cost. That's what the administration wants to see, that there's a change in the cost. So they were able to show there was no increased length of stay. People weren't getting pneumonia. They were going home. They weren't being readmitted. And once, they could document that they were giving this oral care and it really made a difference, then, people started paying attention. And they went from this one small pilot unit, and then they developed it through a couple of hospitals. There was 8 hospitals. Now, now it's being implemented everywhere. But it really is, whether it makes a difference in cost is what the administrators really want to see.
Okay, great. Thank you. We've just got another question from the audience. Have you implemented written promotional material in the oral health promotion for pregnancy, and how has this been received, and was it effective?
So I think in the video you could see they have those flyers that they made, and we have them in English and Spanish. I don't think they have them in any other language right now. So those are the only written materials that I know of that we're giving out in the actual clinic. I think maybe once they get to the dental clinic, they may get more. But with the students together, they really are educating the pregnant woman on the need for oral health, because a lot of people never even mention that to their pregnant patients. So in the prenatal clinic now, every pregnant woman has to see the dental team, and they're getting educated. Now, whether anybody tells them anything else who are not part of the dental team, I'm not sure, but they are getting the education from the dental team.
Great. We might just do the last question. It's from Jenny. Do you see a role for allied health and medical in this space?
So is the allied health? Well, I know.
So here, allied health, I guess, is dietitians, physiotherapy, speech path.
Yes, definitely. So although we haven't really integrated that into our programs, but because mainly we don't really have those students, but we go to the community colleges, and there's a nurse program in the community colleges, and the community colleges are much better at having all of the different specialties. So we work with them, just giving programs at their conferences, and it's get them to work with, they have respiratory and social work and pharmacy, and they have everything in the community college, which we don't really have a lot of that in our school. So I think that's where we're seeing it a lot more, where people can have a lot bigger teams. Also in the VA, on their team, they have all of the specialties, speech and swallow and respiratory. And we have it on our mucositis inpatient team, but in the college, we don't have those specialties to work with.
Great. All right. I think we've run out of time, but thank you so much, Erin, for your presentation. You're welcome to stay, but I know it's getting late there. But if I guess we will when we circulate the recording to the audience, we will include Erin's email address if anyone has any specific questions you'd like to pose to her, or get some support with some resources. So thank you again, Erin.
Thank you. Thanks for having me. No, I'd like to stay and listen. I'll turn off my camera though. Okay.
No problem. Thank you.
Thank you.
All right. So I think now we will start our sessions of short presentations. So I'm going to hand over to Dr. Leanne Hunt, who's a senior lecturer in the School of Nursing Midwifery at Western University, to chair the first session. Over to you, Leanne.
Good morning. Thank you very much for the invitation to chair the first session, Ajesh. Appreciate it. So this session will focus on projects involving co-design models of care with clinicians and consumers to meet the needs of the population. Just for people who wish to pose a question, if you could use the Q&A function and not the chat function, we would appreciate that. And we'll pose the questions to the presenters at the end. There will be one recorded presentation, but feel free to still pose questions and we'll forward them on to Amy for her response. For the presenters, you will get a cue at when there is 1 minute remaining for your presentation, and it will be a bell, I believe. So the first presentation is Dr. Paula Sanchez, who will be talking about cardiovascular health. So Paula? Hello.
Hello. Hello, Leah, thank you very much. And I'd like to acknowledge that I'm standing in Aboriginal country with the Darug people, and also for everybody else that's standing in Indigenous country, Aboriginal country. It always was and always will be Aboriginal country. Thank you. So I want to talk about my introducing oral health in the cardiac setting. Next slide, please. So many of us already know there is a link between oral health and cardiovascular disease and stroke, and it is to do with inflammatory processes, to do with inflammation, increasing the risk of developing arteriosclerotic plaques and therefore cardiovascular disease. Next slide. So a bit of the background. Because of this connection, there is international and national guidelines recommending to include oral health promotion and oral health in the cardiac setting. Through my doctorate, which I already finished, a cardiovascular oral health study, it was found that in Australia, there is limited knowledge among cardiac care clinicians and patients. And when I talk about cardiac care clinicians, I'm talking about nurses, physiotherapists, and all the healthcare team working with cardiac patients, and also patients. We also found that among clinicians, there's lack of training and resources to provide patients. And there's resources for patients and resources for clinicians to provide oral health to this population. So next slide. So working with cardiac care clinicians and allied health people, and you can see some photos of what I was collecting data. We were working with cardiac care nurses, physiotherapists, exercise physicians, dietitians. I collected information during my project. Next slide. And one of the things that we did as a result is developing an oral health resource information resource that is now available at the Ministry of Health as a resource for people with heart disease. And this resource was developed by us or by COHORT, but with the support of clinicians, dietitians, exercise physicians, physiotherapists, and also patients that actually looked at this resource and gave us feedback to get the best that we can do, produce. Next slide. Okay, so I'm going to show you a couple of videos of a couple of the clinicians that helped us developing this resource. Thank you.
People with cardiovascular disease, cardiac, should be aware of the importance of other risk factors for heart disease, and oral hygiene, oral care, gum disease is a risk factor. So they need to be aware of how to look after themselves and where to get the information on how to maintain good oral health. I think it will be useful for them so that they can get the information they need.
Yeah. Well, I was a dietitian working on the cardiology ward at the time, and I, just educate so many people about the healthy foods for the heart. But if you really think about all of the foods that are good for the heart, they're also good for our oral hygiene and things. So I thought, collaborating with something like this to, not only talk about healthy eating for the heart, but also for the teeth, it can, contribute to both health in both areas.
Thank you. Thank you, Amy. So moving forward, we'll continue to work on this project. And the idea is to develop a model of care where non-dental professionals, in this case nurses, can do an oral health assessment, and we develop a referral to patients with cardiac conditions. So thank you very much.
Paula, where have you gone?
So I'm here.
Yes.
So I have the questions.
Yes, I've got a question.
Thank you.
That's all right. So along the same lines of what Ajesh asked, Associate Professor Erin Hartnett, is how did you get buy-in from clinicians? So the dietitian was obviously on board, enthusiastically on board, but how did you get buy-in from other clinicians?
Actually, I think my relationship with the clinical setting and being a nurse myself, I just want to talk to actually clinicians working with cardiac patients. It was interesting that many, first was the lack of knowledge. They didn't know much about the relationship. But once they knew, when they found out that, yeah, there is a very strong relationship and that this can affect patients with cardiac conditions by, having strokes and increased number of recurrent chest pain or angina or myocardial infarctions, immediately they said, look, so we can do something about it. We need to improve the health of our patients, but also talking to them about how practical it would be, because the concern that they had was the timing, staffing levels. We have so much work to do. Adding one more assessment to our daily routine is going to take time. So it's basically talking to them about how short it could be. I actually looked at the model that Ajesh developed with the NEO program, the midwifery initiated oral health, where midwives have a very, very short assessment. It's 2 or 3 questions, oral health, assessment, just look at the mouth and the gums, and they get a referral, the pregnant women get a referral. So something similar where it's not going to be a lot of time. And I think that was the selling point.
Okay, that's excellent. Good work, Paula. Thank you very much.
Thanks, Leah.
Thank you.
So good.
Thank you. Okay, so the second presenter is Prakash Prudel, whose topic is related to diabetes. Thank you, Prakash.
Thank you, Leah, and welcome everyone. Good morning, everyone. So today I'm talking about diabetes and oral health. So this is just a continuation of our today's business, making oral health everybody's business. So among the oral health and other systemic illness, there are, like Paula just highlighted, about the cardiovascular, and there are onwards presentation which will talk about pregnancy and other conditions. So among the other systemic and oral health conditions. So diabetes has a well-established evidence and a link. The research has been done over the last 30 years or more. So I will present overall summary of my PhD study today. Next slide, please. So that's to start with a background on the link. As you can see, there is a two-way link between diabetes and oral health, which says there's a bidirectional link, which said that diabetes, especially poorly controlled diabetes, not only increase the risk of different oral health problems, particularly gum disease, periodontal disease, and in turn, periodontal disease also could impact on the glycemic control and worsen the diabetes complications. And as you can see, the logos over there, there are different guidelines that have been endorsed from Royal Australian College of General Practitioners, Diabetes Australia, which has been saying that oral and periodontal health review should be incorporated as part of the diabetes care. But we didn't know what was happening at that time. So that's why we wanted to do this literature review to find out what is the current evidence. So we conducted two studies. One was looking at the care provider's perspective. The other one has looked on oral health knowledge, attitude, and care practices of the patients. So both of these reviews identified that currently at that time that they didn't address oral health as part of the diabetes continuum care. And what are the reason behind that was there were definitely barriers, including limited oral health knowledge and time consent for the care providers, while the lower priority of oral health among the patients. So unfortunately, we didn't find any studies from Australia. So that's what the significance of my PhD was. Next slide, please. So the PhD of the project included a mixed method design, including a qualitative component for the diabetes care providers and a quantitative survey with the patients. So the overall aim was the need assessment to inform some kind of development of oral health program in diabetes care settings. So as you can see, the findings from the qualitative and quantitative parts, but probably I will not go through all the details, but just to summarize that oral health, that the clinicians found is very important to address as part of the routine care, but they were not doing that because of the barriers such as limited time in diabetes clinic practice. There were not resources such as oral health education resources to educate patients about oral health issues. And similarly, there were no identified prioritized referral pathways so that they could send the patients who are identified at risk to the dental care services. So that was the challenging. So that's why they wanted to get the brochures, sort of screening tool to facilitate them to screening and prioritize the referral pathways so that they could send the patients to dental care services. While at the patient's level, they definitely found the oral health as a low priority because they've been dealing with other comorbidities. That's why they've been facing stress, and the oral health may not be a priority for them. As clinicians, some of the clinicians also told that because we have 2 ears, 2 eyes, and there are many teeth, so losing one teeth is not a problem at all. So that was one of the quotes that clinicians said. So that shows the lower priority of the oral health among the patients, and because the cost is definitely a major factor, because most of the patients didn't have the private health insurance, so it's good facilitate for the timely dental visits. But the most important part from the both phases, from the clinicians and patients, was they both found very receptive to incorporate oral health in the diabetes care. So that was the promising results. So next slide, please. So what I can conclude from my PhD is that there is an unmet need of the patient in terms of they are not educated, they are not getting the timely dental care, but they want to be receptive. They want education, information, and referral. Similarly, the diabetes care providers practices are limited, but they are receptive to incorporate oral health if they are facilitated by oral health resources, screening tool, and referral pathways. So they also highlighted that a team care approach involving all the dietitian, the GPs, endocrinologists, and nurses could enable this new model of care. So that was the findings of my PhD, and we've been working to translate that findings. Next slide, please. Which is, we have already developed a brochure, which is freely available through Center for Oral Health Strategy, and anyone can order through that through that website. So I have provided that scanning code for that website as well. And we have developed a scoring tool, which is in the process of validation and has been found very highly sensitivity and specificity, which means that can correctly identify the people who are at risk of oral health problems and exclude those who are not at risk. Similarly, we are also working to develop the training program for the diabetes educators. And I would like to highlight the importance of collaboration and what that resulted in the clinical practice through one of the clinicians' mouth. This slide. So I would like to play the video here.
My name is Cecilia. I'm the clinical nurse consultant in diabetes at Liverpool Diabetes and Endocrine Services. We participated in the Diabetes and Oral Project. We were invited by the team to actually give our point of view of what is happening really in practice. As diabetes educators, oral health probably has been one of the things that we know that they are important, but have never been enough tools or resources for us to apply to our day-to-day encounter. Collaboration within this team has given us very positive outcomes. One of them has been a training program for diabetes educators in oral health that they can be used to teach and assess patients. And one of the important tools that they were developed is actually this brochure that allows for patients in a very simple manner to actually understand oral health and to do some self-caring.
Right. So just before I end my presentation, we have also worked with Ministry of Health Nepal to translate that brochure into Nepali language, which will be covered at the end of the session. So that's the end of my session. Thanks, Lian and everyone.
Thank you. Thank you, Prakash. We're going to leave any further questions till the end of the session. Okay, so thank you very much, Prakash. So the next presenter is Amy Villasaro, who's talking about eating disorders, and this is a recorded session. So again, if you've got any questions, pop them up into the Q&A. Thank you, Tiffany.
Hi everyone, my name is Amy and today I'm going to be presenting how we co-designed implementation strategies for children's growth assessment guidelines in the dental setting, also known as the CHEWI project. As this was part of my PhD, I would first just like to acknowledge my supervisory panel and the support that they have provided through this project. So we know that childhood obesity is a national priority and that it affects many aspects of a child's health through to adulthood. As a result, in New South Wales, public services are required to monitor height and weight, promote healthy food choices and physical activity for all children, and this includes in the dental services. Senior dental therapist Cynthia Valderrama will explain the exact practices involved.
Hi, I'm Cynthia Valderrama. I'm a senior dental therapist. My role as a clinician is to provide routine growth screening, which is taking the height and weight measurement and calculating the BMI percentile, and then record the result into electronic record. Also engaging in discussion with the parents regarding the result and providing initial management and referral pathway if required.
With new practice guidelines, there are challenges that need to be overcome.
The challenges that I've encountered with parents when obtaining consent for the growth screening are the following. Language barrier. Due to high population of non-English speaking background, interpreter is required to help translate. The other challenges, lack of knowledge and awareness of the impact of well above and below healthy weight to overall health. Also non-compliant due to parents and particularly teenagers are not interested.
Depending on the perspective of different people, they may see a challenge differently. Principles of co-design can incorporate these different perspectives into one overall solution. Therefore, this study aimed to use the principles of appreciative inquiry to co-design implementation strategies for these new guidelines. Focus groups were conducted with dental staff and parents across South Western Sydney Local Health District and Nepean Blue Mountains Local Health District, and they were analysed using content analysis. When discussing aspects that would help with children's growth assessment guidelines in the dental setting, two themes emerged. The first theme encompassed strategies to support staff to engage in the guidelines, including increasing their intention, ensuring they had adequate skills, knowledge, and awareness, and also reducing any environmental barriers to engaging in the guidelines. The second theme encompassed strategies to engage patients, including ensuring they had information to set their expectations before the appointment, ensuring they were adequately informed about healthy weight in childhood during the appointment, and ensuring they were adequately linked to their referral pathways following the appointment. These themes were used to develop a series of strategies, which for dental staff included refreshed training to improve their knowledge and skills, involving dental assistants in the growth assessment to improve intention, and also informing staff on how to use longitudinal BMI measures in their assessment. For parent, strategies included providing information about the growth assessments with their booking reminders, translating resources for people from culturally and linguistically diverse backgrounds, and ensuring discharge summaries were sent back from referral pathways. The significance of this project is that it is meeting a national and state priority, and it is filling an area with no existing research. In terms of future directions, these strategies have now been refined by working committee and are currently being implemented and evaluated. So thank you very much for listening to my presentation. If you have any questions, you're welcome to email me. Thank you.
Lovely. Thank you, Amy. Okay, so our last presenter in session one is Tiffany Patterson-Norrie, who will be talking about eating disorders and oral health. Thanks, Tiffany.
Thanks, Anne. So the title of my presentation is Dietitians Promoting Oral Health in the Eating Disorder Clinical Setting. And I'd just like to acknowledge the support of my supervisors, Professor Jess George, Associate Professor Lucy Ramjan, and Dr. Mariana Sousa. Next slide, please. All right, so more than 1 million Australians are thought to have an eating disorder, and mortality rates can be as high as 12 times higher than the standard for individuals that have an eating disorder. The impact of eating disorders are multisystemic, and they often can affect things like the cardiovascular system, renal and musculoskeletal, but often oral health is forgotten as part of that equation. Individuals with an eating disorder, regardless of their subtype, so whether it be anorexia or a binge purge subtype, can be at 5 times higher risk of tooth erosion and increased risk of dental decay, which is quite significant. Untreated dental decay and tooth sensitivity can impact oral intake, contribute to food avoidance, and impact treatment and rehabilitation. The significance of research has shown that both dental and non-dental health professionals can play a role in promoting oral health and support this happening in especially vulnerable populations, such as those that may be experiencing an eating disorder. However, the results from a scoping review that we conducted as part of phase 1 of my PhD project indicated that there is a paucity of available resources for individuals and for health professionals in promoting oral health in their practice. And this is needed in order to inform the need for oral health promotion, as well as to support this population. Next slide, please. So in order to go about doing this, there were 2 parts to this process. So first, I wanted to develop a national survey to consult with dietitians to understand what exactly are their oral health promotion challenges and facilitators in promoting oral health generally across many clinical areas, but also wanted to understand what are the resources that are available for clinicians in promoting oral health for those individuals that specifically have an eating disorder. So part of the 2 branches, I needed to first start off by identifying key clinicians. And I did that by firstly looking into my network. So I'm specifically a clinical dietitian. And through my network, I was able to find Lindy Sank, who is also a dietitian that works in Sydney Dental Hospital. I approached her, engaged her interest in the project, and because she was interested to participate, wanted to include her as an expert informant on a panel to help develop the national survey. So I used that in conjunction with the literature that we'd found. So I'd gone through and done a literature search and looked at what are the other available surveys that have that have done their survey, with other health professionals and specifically allied health professionals, and use Lindy's expertise to help guide us to identify what information will be important for us to gather in terms of dietitians promoting oral health. The survey was then developed and we did a pilot process, again, taking that back to the expert panel to get their feedback, as well as piloting the survey with a small proportion of the target population of dietitians. The survey was revised and then disseminated. We then looked at the fact that we need a resource to promote oral health among populations with an eating disorder. And so to do that, we looked at what are the important stakeholders that we need to engage. And one of them that came up was the National Eating Disorders Collaboration and the Butterfly Lived Experience Collective. And so we went and approached the National Eating Disorders Collaboration for support to how to engage this particular population, but most importantly, considering things like what is the appropriate terminology to use, and also looking at what are the things that will be appropriate to put in a brochure and an oral health promotion resource. The National Eating Disorders Collaboration, Australian Dental Association, Ministry of Health, and a few other stakeholders came together to form a working group. So we tried to get a whole variety of knowledge and input from stakeholders. And this was just done by sending out emails, making phone calls, and trying to engage those particular groups after developing a project proposal. We then came together and had multiple meetings over which we discussed all the important things that are needed to develop a resource. And then a draft resource was developed and the piloting process began. So again, that was going out to the stakeholders to get their feedback and to their networks, as well as approaching the consumer group. The resource was then revised and then we produced the final resource. So we approached the Butterfly Lived Experience Collective in order to help provide feedback for this resource. So in the Lived Experience Collective were participants that have had an eating disorder, and they were able to provide feedback to determine how appropriate their resource was before we then approached the final stakeholders to get the resource printed and disseminated. Next slide, please. So the benefits of co-design. So I feel like approaching the clinicians and the stakeholders directly helped us get their specific insight and expertise to make sure that we were doing the right thing. Sometimes when you're approaching it from a research point of view, and mental health not being my specific clinical background as a dietitian, you can feel a little bit lost trying to work out how exactly you engage that particular population and make a resource or a survey that is appropriate and acceptable amongst the population you're planning to engage. So getting on board these people that are really insightful in that particular clinical area, I think is absolutely vital. And as I said in the next dot point, it helps synthesize the practical and theoretical experience into the resource or the survey that you're developing. And it also allows for other people to contribute to research and public health promotion without actually having to go ahead and conduct the study. So if you're interested in being a part of research but don't really want to lead the entire project, this is a good way for you to get that satisfaction and involvement. And that's it. Thank you.
Thanks, Tiffany. All right. So if anyone has any questions, please do put it in the Q&A box and we'll get to them. But I have a question, Tiffany, for yourself before Prakash makes his way back up to the podium. So just so it's clear in my head, at the moment, you have got a project, but it hasn't been implemented at patient level yet?
So so I'm doing the PhD project. Yeah. And firstly, what we've done is we've developed a scoping review, and we've completed the scoping review to look at what dietitians are doing in the eating disorder clinical setting, which we found they weren't actually doing anything at the moment, but they are actually providing oral health promotion in a variety of other clinical areas, such as women, infant and health, and aged care population. We then took that information and said, okay, well, I really want to understand what this looks like in the Australian setting. So we got on Lindy to assist us in providing her expert opinion to develop a national survey for dietitians in Australia to understand what are they doing generally in terms of oral health promotion. From there, I've gone on to do interviews with both dietitians and clients that have had an eating disorder to understand specifically what are dietitians doing and how does the consumer, what do they feel about that. But in terms of the oral health promotion resource, from the findings of the scoping review and just from some preliminary data with the dietitians, we're able to understand that there are some resources out there that specifically look at oral health promotion for clients with an eating disorder, But we felt that we wanted to provide something more specific and with the endorsement of the Ministry of Health and the Australian Dental Association and the National Eating Disorder Collaboration and Butterfly and so on. And so in order to do that, we needed to engage some more stakeholders. So it's a few branches of the model that have come together, and we're just kind of, making them go along.
That's excellent, Tiffany. Thank you. I'd be really interested to hear how it goes, what the impact is on the ground when you get to that. I know that's a long way away, but when you get to that, really interesting because they're a complex group of people.
Yeah.
Yes. Yeah. So really interesting. Thanks, Tiffany. Prakash, thank you very much. Hi. So you mentioned early on in your or the first part of your talk that diabetes, the link with diabetes and oral health problems has been long known. We've known that for a long time. Why do you believe that has not been a specific target before? Because you've demonstrated, I'm sure it wasn't easy, but you demonstrated how easy it was to, promote, as Paula has, and as Tiffany has as well, how easy it is to target. So why do you think it hasn't been done before?
Yeah, there has been some small efforts to incorporate oral health into the diabetes care, but definitely as I identify the barriers like resources, there were not adequate resources such as education resources or simple screening tool that could facilitate in that busy clinical practice settings, because they have definitely dealing with other issues because other complications. So definitely oral health is not a priority for the clinicians and patients as well. So that's the reason behind not incorporating as part of the routine care. So considering those barriers, definitely we need to develop that sort of resources which could facilitate to carry out a short intervention like within 2 to 3 minutes. That's the most of the clinicians do that. It should be a short, like 3 minutes. They could educate the patients, do the screening, and initiate the referral process within that 3 minutes. So there are not such resources available to facilitate the clinician to carry out those tasks within a short period of time. So I think that's one of the most challenging or major barrier.
Okay, thank you. That's interesting. It would be interesting to see if you collect some data on what the impact is, down the track. Yeah. No pressure, Prakash, at all.
Yeah.
Thank you.
That's for the postdoc. Yeah.
Postdoc, yep.
Great.
Thank you, Ajesh.
Was there another question? Do medical practitioners engage with dental practitioners with regards to diabetes or health promotion? Prakash, answer quickly.
Yeah. So there has been a voice for the interprofessional collaboration as well. Definitely not. And in the current situation, there is no the collaborative practice. So that's one of the aspects we need to do while developing any new model of oral healthcare. So that's an important question. Thanks for raising that one.
Yes, Ajesh, can I just say one more thing? Just sure. Those 4 presentations just highlight how important it is for us all to work across professions, I guess, nursing, dental, dietetics, etc. We all need to work together to have, the ultimate impact, I think.
Thank you. That's right. Well, thank you to those presenters. So now we're going to have a very short break, probably only about 5-6 minutes, morning tea break. So if you guys want to come back at 11:10, we will be starting session 2. So thank you. Okay, welcome back, everyone. So our next session will be chaired by Associate Professor Lucy Ramjan, who's an Associate Professor in the School of Nursing Midwifery at Western Sydney University. Over to you, Lucy. Thank you.
Thank you, Professor George, and good morning, everyone. This session will focus on projects that address the oral health of priority populations. Please use the Q&A function to pose any questions you have for our presenters in this session. If your questions are for a recorded presentation, the team will convey them to the presenter. Presenters, please note you will hear a bell sound when you have 1 minute remaining. First up, we have Alicia Johnson.
Good morning. My name's Alicia Johnson and I'm a CNC at Banks House Mental Health Unit, and I'm also a PhD candidate at Western Sydney University. Today I'll be talking about my area of interest and PhD focus, which is the oral health of adolescents with mental illness. Next slide, please. So my interest in oral health in individuals with mental illness came about through my experience working within Southwest Sydney Mental Health. I've been working in Southwest Sydney Mental Health inpatient units for the past 7 years, predominantly in adolescent and youth mental health settings. So I found that I was frequently administering nurse-initiated paracetamol and PRN paracetamol for toothache, as well as antibiotics for oral health issues such as abscesses. But it wasn't until I was working in the mental health high dependency unit where I had a young male in his early 20s who I had to order a soft diet for because he had significant tooth loss and was unable to chew, which meant that this impacted on his nutritional status as well as his mental health recovery. Additionally, there's also a lot of evidence available that demonstrates that individuals with mental illness often experience poor oral health compared to those who do not have a mental illness. And we also know that individuals with mental illness are at higher risk of metabolic related illnesses, which also have an impact on oral health. Next slide, please. So firstly, understanding the problem, after a literature review is conducted, a national survey will be conducted looking at the knowledge, experiences, current strategies undertaken by mental health care providers with a subsection for adolescents. From here, interviews will be conducted with mental health care providers that provide care to adolescents with mental illness to understand facilitators' barriers to providing oral health care promotion in the inpatient setting, as well as if they feel there's a role that they can provide in promoting oral health. Additionally, interviews will be conducted with consumers and their carers to understand their experiences with oral health and whether or not there is a role that can be played in the inpatient setting to promote oral health. So after exploring the experiences through the qualitative process, strategies and potential interventions will be come up with through collaboration, and then these put forward to the consumers, their carers and other stakeholders, including executive leaders and professional bodies. Next slide, please. So the aim of these interventions and collaboration with those that work in the inpatient setting will be to improve the oral health of adolescents with mental illness and to hopefully be able to educate them and provide them with the skills to go on to have long-term oral health benefits and practices that will reduce them having future implications with their oral health. Thank you.
Thank you so much, Alicia. We'll move on to our next presentation. Our next presentation is Prakash Paudel.
Thanks, Lucy. So my name is Prakash Paudel. I work in drug health services as a research coordinator. So today I'm presenting about the needs of oral health care in alcohol and drug settings. So next slide, please. So just a brief background why oral health is important for the people who are dependent on alcohol and other drugs is because it has alcohol and other drugs have a direct exposure to oral tissues and cavities. So that's why there are a range of oral health problems coming from the substance dependence. So like there is a dry mouth, alteration in sensation and taste, mucosal infection, and which ultimately lead to gum disease. So that's why the importance of maintaining good oral health care is in people who use drugs and alcohol is very important. But very less is known about how to promote oral health in drug and alcohol setting is the current situation. That's why the project is all about. Next slide, please. So the aim and phases of this oral project is to develop, implement, and evaluate oral health care program with components of several phases. starting from the review and then going through the need assessment with qualitative and quantitative interviews and surveys respectively. And then in the last phase, we'll be developing, implementing, and evaluating different models of oral health care. And as part of this early phases, we have completed a scoping review, and we are in the process of doing the interviews, which is a need assessment with alcohol and drug clinicians. So I'll just briefly talk with the results of the scoping review. Next slide, please. As there are some guidelines which I've been talking in international setting as well as in local setting that alcohol and other drugs clinicians should play a greater role to promote oral health among those clients, because these clients are very vulnerable and they have other comorbidities that, like mental health, that also puts challenging in terms of like they have a challenging behavior, risk-taking behaviors, like they have been consuming high the foods and drinks with high sugary, which ultimately impacts on dental cavities. So that's why this is important to promote oral health among those patients. And there are guidelines, but the chances of that guidelines into practice is limited. So the scoping review pointed out there is really not any intervention that shows that these conditions are really complying those guidelines. And similarly, there are some interventions like providing the education involving the social worker or in the alcohol and drug setting, like supervised injecting rooms, like doing the health promotion, doing X-ray, and providing the topical fluoride could improve oral health of those clients. So that's so that the alcohol and drug clinicians could play an active role, a proactive role to promote oral health among those patients and facilitate to access the dental care, which is very challenging for those patients. So that's why the future research definitely need to identify the needs of the alcohol and other drug clinicians so that they could more effectively promote oral health among the clients. Similarly, that should find a strategy to promote oral health among the patients, because the patients have often low literacy, they have other priorities, and they often face barriers in terms of the cost and support to access the dental care. So these are the findings from the scoping review, and we'll definitely present on another avenues about the results from the qualitative interviews. So that's the end of my presentation, but I'll be happy to take questions on later Q&A session. Thanks, Lucy, and everyone.
Thank you, Prakash. Our next presentation has been recorded and features Dr. Nidhi Saraswat.
Hey everyone, this is Nidhi Saraswat. I'm a dentist by background, currently a PhD student at Western Sydney University. Before moving forward, I would like to say that I'm really thankful for this opportunity to present my research on this platform. Since I'm currently overseas due to COVID, this will be a recorded presentation. Today, I'll be presenting on topic oral cancerous behaviors of Indian migrants in Australia, which is based on my PhD project. Oral cancer is one of the top 10 cancers prevalent, with average annual incidence of almost 300,000 cases worldwide, where majority of cases are diagnosed in advanced stages. As you can see, the brown colored area on the map on this slide depicts the countries with high incidence and mortality rates of oral cancer. Here, South Asian countries like India, Nepal, Pakistan, Bangladesh, and Sri Lanka are most affected by oral cancer, along with some other parts of the world. Oral cancer is a leading cause of cancer-related mortality in India, where it ranks among top 3 cancers, accounting for more than 30% of all the cancers reported in the country. In Australia, Indians are one of the fastest growing communities, forming about 2.6% of the total population. It is a general belief that migrants carry their cultural beliefs and practices with them to the new settlements. An increase in the registration of new cases of oral cavity and lip cancer over the recent years could be explore oral cancer behaviors of Indian immigrants and related perspective and practices of GPs in Australia. So after intense literature review, we found that this was an under-researched area in Australia, and that's why we employed a sequential exploratory mixed method design and conducted study over 2 phases. The phase 1 was qualitative and phase 2 was quantitative. Phase 1 constituted concurrent semi-structured interviews with 14 Indians and 14 GPs across New South Wales and Victoria. These 2 states are preferred states of residence among Indian immigrants. Phase 2 was quantitative, which constituted a cross-sectional survey with Indian immigrants across Australia. So what are the key findings from this research? Phase 1 revealed that oral cancerous practices like tobacco, chewing, betel nut use are common among Indians. They also have limited knowledge and varying attitudes around adverse effect of areca nut preparations. On the other hand, GPs showed overall good oral cancer knowledge, but they had limited information about new risk products like betel nut. They also had varied beliefs about the seriousness of oral cancer in Australia. Inconsistent clinical practices around routine oral checkups and preventive counseling relating to oral cancer came into light. Phase 2 revealed that just over half of participants had good basic oral cancer-related knowledge, with varying attitude towards it. More than 20% were found engaged currently or in past in betel nut chewing practices. This analysis is in progress currently, and we will know more soon. Coming to conclusions and implications. Research showed that Indian immigrants have insufficient oral cancer-related knowledge and have inclination towards negative risk practices like betel nut use. It also showed that GPs have limited knowledge about new oral cancer causative products like betel nut and have inadequate clinical practices relating to preventive oral cancer counseling and routine checkups. It also showed that there's a scarcity of educational resources and training in this area. So in that context, we recently developed a fact sheet for health professionals regarding areca nut preparations in collaboration with New South Wales Ministry of Health. The link is given in the slide. We are also in the process of developing another educational resource regarding awareness of betel nut chewing for migrants. So thank you very much for listening to my presentation. For any queries, you can contact me on my email ID. Before wrapping up from my side, I would like to request you to watch the video from my co-supervisor, who is also a clinician. The video will be played next. Thank you.
Thank you, Nidhi.
My name is Dr. Neeta Prabhu. I work as a senior staff specialist at Westmead Hospital and head the discipline of pediatric dentistry at Sydney University. Now, I first became interested in learning more about betel quid chewing habit during my time in London, where I researched betel quid chewing habits amongst Bangladeshi children living in East London. So fast forward several years, it so happens Professor Ajish George contacted one of my supervisors in London, who then suggested for him to reach out to me here. And that's how I became involved with Nidhi's project. Now, to some of us wondering what's betel quid and what is, and how does this habit actually influence the overall well-being of individuals? Well, to put it simply, betel quid is the betel leaf to which areca nut, slate lime, tobacco, and several other ingredients are added. It then makes up the betel quid, which people then chew or suck, or some retain it in their oral cavities for prolonged periods of time. Now, it is actually an integral part of certain cultures and is widely practiced in certain communities. Unfortunately, though, prolonged use of the substance can cause oral cancers. Again, looking at published literature, we know that Southern Asian countries report the highest levels of oropharyngeal cancers, with mouth being the most common site. In India, it has become a national public national public health concern, again attributed to increased levels of cancers because of tobacco, either chewing or smoking, and alcohol. So why is this all important to us here in Australia? Now, we know with increasing levels of migration from the Indian subcontinent, coupled with easy access to these products here in Australia, it becomes absolutely vital for us to explore the risk behaviors of Indian migrants living here in Australia, coupled with simultaneously accessing or rather exploring the knowledge of general medical practitioners towards these risk behaviors and actually towards betel quid chewing habit. We hope that the findings from our study will help translate research into clinical practice by developing culturally appropriate tools, as in the form of preventive and educational interventions and targeting specific oral health promotion messages.
Thank you. Our next presenter is also recording, and it is Dr. Richa Acharya.
Good morning, everyone. My name is Richa Acharya. I'm a Master of Research graduate from Western Sydney University. Before starting my presentation, I would like to thank my supervisors, Stacey, Ajesh, and Harrison, for making this project possible and supporting me throughout my Master of Research degree. So out-of-home care is a living arrangement for children aged 0 to 17 years who are not able to live with their biological parents for reasons such as mental health issues, parental substance abuse, and many more. So these children have increased burden of physical, developmental, as well as oral health problems. Oral health problems such as dental decay can affect their quality of life, impact their overall well-being. It can cause pain, swelling, and even hospitalization to have dental treatment done under general anesthesia. So these children are cared by foster kinship carers on a day-to-day basis. However, no studies so far have highlighted the experiences in doing so. So a qualitative study that included semi-structured interview of foster kinship carers across different states of Australia found out that all foster kinship carers had good understanding of importance of oral health. They implemented good practices for oral health care of children living in out-of-home care. However, there were some barriers such as improper communication channel between foster kinship carers and the agency, longer waiting period in public dental sector, as well as child constantly moving from one carer to another, known as child transients. Some of the facilitators that was highlighted was innovative strategies such as singing and dancing while brushing to engage children in oral health habits at home, also having a good communication between foster kinship carers and the agency, and also having collaborative treatment planning. So for recommendation, Australia's National Oral Health Plan 2015-2024 lacks that guiding principle for oral health care of children living in out-of-home care. But on the other hand, we have Oral Health New South Wales 2020 that says these children are priority population. So this inconsistency across the policy needs to be addressed, and since out-of-home care system follows a national guideline, we need to have a guideline throughout the country. So in terms of practice, we need to have a good working relationship between foster care agencies and foster kinship carers. We need to have a routine awareness programs where foster kinship carers are made aware and they're updated on how to look after children's oral health and look after their oral health needs. Also, we need to have interprofessional collaboration between pediatrician, dentists, caseworkers, even foster kinship carers to promote the oral health of children living in out-of-home care. And last but not the least, in terms of future research, we need to have cross-sectional survey to confirm the current study findings, explore the experiences of other group of carers such as same-sex couple or people from Aboriginal community, as well as caseworkers. So also we need to explore the barriers and facilitators that is specific to different types of out-of-home care system, given there are fundamental differences between types of out-of-home care. So with this, we are towards the end of today's presentation. I hope you have a good day, and thank you so much for your time.
Thank you, Richa. Our next and last presentation has also been recorded and features Associate Professor Nathan Wilson.
Hi, my name's Nathan Wilson and I'm an Associate Professor at the School of Nursing and Midwifery, Western Sydney University. And I'm here just to talk to you briefly about the stream that I lead in the area of intellectual and developmental disability and oral health. And what I'm going to talk to you today a little bit about is our goal to work toward a systems-led biopsychosocial framework to help solve the problems of poor oral health for people with intellectual and developmental disability. So, in a nutshell, what we know about the oral health of people with intellectual and developmental disabilities compared to the general population is actually very, very poor. And this is due to a number of issues. I guess fundamentally there are significant problems for many people in terms of their independence in maintaining their oral health, a lack of oral health literacy, which comes from having intellectual disability and problems with understanding and reading and writing. Many disabled people, and in particular people with intellectual and developmental disability, experience access barriers to both oral health and other health services. Most significantly, there are many people with intellectual and developmental disability that have got underlying, chronic and complex comorbidities, and that can include deformities to the craniofacial structures that can also lead to additional oral health issues, as well as being nil by mouth, as well as being prescribed polypharmacy and having medications that impact oral health and so on. The final issue is that they've basically got a very, very heavy reliance on caregivers for that situation and start looking at potential solutions. So, looking at the Australian context, we're talking about the NDIS workforce here, and they're a largely very unregulated, heavily casualised workforce with very high staff turnover. What our goals have been over the last 3 years have been to firstly scope the breadth and depth of the problem, explore knowledge and barriers in the disability support workforce, and to start looking at exploring and testing potential solutions that are going to, fit the context of the NDIS in Australia. So over the last 3 years, we've published 2 literature reviews, one that scoped the problems and one that scoped the potential solutions. We have looked at a oral health champions program that was ran down in Victoria at a disability service, and we've just resubmitted a paper where we looked at the experiences of those champions in the oral health champion program. We're just finalising an evaluation of the Smiles for Life oral health training, which is led by Westmead Special Needs Dentistry Unit. We have conducted a national caregiver survey, and we're just analysing the data now. And Ajesh and I are also named investigators. Ajesh, a chief investigator, myself an associate investigator on an NHMRC grant application that's focused on the oral health of children across Australia. So that's basically where we're at the moment. This schema here was something that I designed in the last week or two as I'm starting to, try to conceptualise the different problems and the different solutions. And so if we look at the diamond at the top and the diamond at the bottom. That basically is a continuum between having significant and multiple oral health issues or having few at the other end of the spectrum. And then the two diamonds parallel, we've got on the one side pervasive need for care and support, and on the other side infrequent need for care and support. And so the way that I've basically conceptualized this is that for those at the top right hand side there that have got both significant and multiple oral health complexities and a pervasive need for care and support, that they need their oral health needs overseen and led by a registered nurse-led model of care. And then if we go to the bottom left-hand side, where people will have very, infrequent or minimal need for support and very few oral health issues, that's a model of care that can be led by support workers with input from the multidisciplinary team. And then, on the top left-hand side and the bottom right-hand side there, we've basically got what I refer to as graded delegation and oversight by an appropriate health professional. So this is just, it's an early conceptualization at the moment, but it's a starting point for us. And so this is going back to the title of this short presentation, where I'm looking at that biopsychosocial and systems-led model. By systems-led, I mean different responses for different people in different contexts, underpinned by the evidence and underpinned by the appropriate level of skills and qualifications in the staff that are providing that support to them. So it's early days. Ajesh, myself and others that are working in this area are very excited by what we're doing. And we hope to get some grant success in the future to carry on the early work that we've been doing. Thank you for your time. There's my email address if anyone wants to email me. As I mentioned, we have published a few papers, so please email me if you're interested in receiving a copy of those journal articles. And thank you.
Thank you, Nathan. So what a wonderful session we've had with some excellent presentations from people. Please do pop in any questions you have in the Q&A box. But I do have a question for Alicia. Hopefully she's still there. Yes, you're not going to get away without a question. So Alicia, thank you for your excellent presentation, and what a wonderful topic, looking at the mental health, people with mental illness and the oral health needs. I know that it's early stages and you're only looking at doing a scoping review at the moment. However, I was interested in the process that you're going to employ in terms of developing some of the strategies or interventions with this group. And we just came off a session on co-design. So I was wondering, are you thinking about co-designing and working with individuals in order to develop the interventions?
Okay, so the interventions and strategies that will be developed based on the qualitative analysis and what we find out from the consumers themselves and their carers, as well as the mental health care providers, as well as looking at what's currently being done, if anything's being done at the moment in settings that haven't actually been published, so informally by mental health care providers, and whether or not that would be feasible to be able to implement in the inpatient setting in the adolescent environment. So it will be based on the information and analysis that we get from actually speaking to and understanding the experiences of consumers and those mental health care providers.
That's great to see, so that you can have the involvement of all stakeholders as well as consumers and carers involved in the process.
Yes.
That's great. I was also interested in, I know that with people with mental health conditions or illnesses, sometimes it's difficult to motivate them and encourage them. So have you been thinking about strategies that might be successful with young people and young people with mental illness?
Yes. So it depends where that lack of motivation is coming from. Often it can be a symptom of their illness and where they are, what point in their recovery they're at as well. Are we talking about consumers that have had early diagnosis and haven't actually commenced on any medication, and whether or not those interventions would be viable to be commenced at that point, or when they're a bit further along in their recovery and have got a little bit more motivation in conjunction with other therapies. So it really does depend, again, where the consumer is at in their recovery. There is techniques available like motivational interviewing and things like that to be able to help consumers along in terms of motivation and finding out where that lack of motivation is coming from. Is it because they're feeling tired, they're too depressed to be able to get out of bed and be able to engage in those health promotion activities, behaviours? So it really does depend where that consumer is at.
Fantastic. We do have a question in the Q&A box from an anonymous attendee, but have you thought of including any clinicians from the oral health team to be part of your project?
Yes. So when it comes to developing interventions, we will have an expert panel, as well as an expert panel in designing the national survey as well, which will have oral health professionals on that as well, because it's really important to get them involved as well.
Great. And there's another question. I know that yours is going to be focused on young people, but any targeted programs for older people, are they a priority population?
Yes, so when you look at the literature, a lot of it is conducted in the space of adults with mental illness, and we do know that they do have significant oral health issues. We also do know from the literature that adolescents that have experienced mental illness do go on to develop mental illness later on in life at times, and from a lot of consumers I've spoken to, a lot have developed those symptoms in adolescence. So starting off small, targeting that population and developing preventative strategies that will lead on into adulthood would be the initial focus. And then post-doc, I would love to look at the experience of adults with oral health as well, issues with mental illness, yeah.
There might be some room for translation of what you're doing currently to different population groups as well. I think someone's also posed the same question for Nathan, so we can send that question across to Nathan. Nathan's not here today, but we can definitely do that and Nathan can respond. Okay, so I might now ask Prakash a few questions. So thanks, Alicia. Wonderful presentation.
Yes, Lucy.
Hi, Prakash. So I've got a couple of questions for you.
Yep.
So your presentation was great. So it's great to see that you're addressing the issues for the area of alcohol and other drugs. When you did your scoping review, was there something in the scoping review that really surprised you that you found out through that scoping review?
We did find that there are some guidelines talking about the oral health promotion as part of the opiate treatment program. Mm-hmm. So that was surprising. That was positively surprising. So that's good to know that there are some guidelines talking about that aspects, but the importance is to translate that into real practice settings. So that's quite challenging because of the clinician time and also because of the vulnerabilities of the patients we have in the drug and alcohol setting, because they do have other comorbidities like mental health, cognitive decline, and they have like risk-taking behavior. So that's very challenging.
Yes, exactly. So that while there are guidelines in place, the translation of those guidelines in practice is the issue at the moment. So can I ask you, what's one way that people listening to your presentation today could possibly promote awareness of the issues and support translation of those guidelines into practice?
Just before answering that one, I just wanted to highlight as well that there is a treatment for the opiate dependence, like the methadone, which is also a problematic in the sense that they have a higher sugary content as well, which is also adding the problem. So that's quite challenging for the clinicians to address those aspects. But the only thing currently they could do is just to educate patients about that there are oral health risks of the consumption. So you need to care after your mouth as well. That's the only thing they could do at this time, because they are not capacity built to promote oral health in a very effective way. They don't have any resources, they don't have any skills and confidence to talk about oral health as part of their clinical care. So I don't really want to emphasize that they could do, but they just can refer the patients to do a dental visits, regular dental visits, at least like 6 months or yearly dental visits, so that the oral health problems could be identified earlier rather than later. So that's the only thing I could probably encourage the clinicians to do at this point of time.
No, that's fine. So encouraging referral to a dentist or an oral health professional. And after your PhD, obviously, your project, because you've got your PhD, after your project, I think clinicians will obviously have the skill set and the knowledge, and you will have developed some resources that they can use in their practice.
Yeah, exactly. In the meantime, they could just promote good oral hygiene behaviors, that's all.
Great, excellent. And I was just interested, what motivated you to do this project?
Definitely, this is coming out of my PhD project, because I was working on diabetes and oral health, and we have already highlighted that there is a systemic link between various illness and diseases. So, and nobody has touched this aspect in detail. So that was a gap, and they have been facing so many issues, and they really don't look after their oral health. So that's the most important part. That's driving me to initiate this project, Lucy.
Great, fantastic. So I think we've had some really excellent presentations across a really broad spectrum of topics. And we do have in the chat a question for Associate Professor Wilson, and we will pass that one on. Is there any partnership with specialist teams, or maybe Ajesh can answer this one. Is there any partnership with specialist teams for people with intellectual disability Sydney in your project?
So the project that Nathan was talking about is being led by WA, particularly NHMRC grant. So I think the plan is to reach out to people in this space to find out that, make sure that we're not reinventing the wheel. So that is in progress. Shilpi, but we're just waiting for direction from the chief investigator in Western Australia. Okay. Well, thank you, Lucy, for chairing that event, and thank you for those wonderful presenters. So we might go on to the next session, which is being chaired by Dr. Jed Monteri, who is a senior lecturer in the School of Nursing Midwifery. Jed, just for information, I think we do have a few recorded presentations today, but I believe through some messages that I've got that some of these clinicians are present, so they could answer any questions posed. So I encourage, I'll just mention Cynthia, Eileen, Sumal, Kelly, if you are online, just send us a chat so that we know we could, basically, we could hear some of those questions. So over to you, Jed.
Thanks very much, Josh, and I welcome everyone, our presenters and our audience for this third session, which is about improving clinical outcomes as part of the Southwestern Sydney LHD and WSU Oral Health Symposium. So I'm very pleased to be here, but before we start, I just want to give you a brief overview of this session. As per session title, it's improving clinical outcomes. So the presentation that we'll be listening will be focusing on the research and undertaken and quality improvement projects undertaken by our colleagues, which targets both oral health and general health outcomes. So same as the first two sessions, the presentation format will be, there will be speakers and there will be a Q&A time towards the end. So I just want to remind everybody once again that if you want to post your questions, please type that in through the Q&A function, as you can see at the bottom of your screen. And as what Josh mentioned, that we try our very best to get our clinician colleagues to participate in these symposiums. So therefore, we have a combination of live presentation and a recorded presentation, which they kindly record the presentation for us to be able to participate in this session on clinical outcomes. So without any further delay, I would like to introduce our first speaker, Slavika Kruse. My apologies if I can't pronounce it correctly. And it's all about childhood obesity. Over to you, Slavika.
Hi everyone,
And it's a
I'm
recorded
Slavica, clinical nurse specialist from Growing Healthy Kids Weight Management Service, known as GHK Service. Today I would like to share a case study that highlights the effect of routinely screening height and weight, and in particular at oral health setting. John is a 7-year-old boy, Aboriginal background, who has a history of developmental disability, childhood trauma, and is currently in maternal grandma's care. Challenging behavior was reported. John has a difficulty controlling his anger, waiting for his turn, and he becomes frustrated when he doesn't get something on his first go. Concerns of John being well above a healthy weight was initially raised by child and family health nurse at routine screening as a part of out-of-home care pathway, and then 4 months later by the oral health team, who emphasized the connection between diet and dental health and referred John to the Growing Healthy Kids Weight Management Service. At referral, John was triaged as affected by severe obesity and was placed on a wait list. 10 months later, John was invited to attend his initial assessment at Growing Healthy Kids Weight Management Service. And this is where grandma reported increased physical activity, increased active play and incidental activity. He bought a bike and did regular rides at park. John also increased structured activity. He joined PCYC with plans to start soccer. Changes to nutrition were also made. Grandma stopped buying sugary sweetened beverages, lollies and salty snacks. She portion controlled discretionary food that was still available at home and increased visibility and access to fruit. She started a fruit bowl and encouraged children to access it as a snack. She ensured water was the only drink and changed lunchbox to include 1 sandwich and 3 fruits. Grandma reported that she was motivated to change once the issue was raised second time, and her big motivation was John's dental health. She stated she didn't want him to have bad teeth. John attended the Aboriginal GOTY program for behavior support. They didn't measure his height and weight, but they did discuss 8 healthy habits. So this is John's progress while he's being on a wait list for GHK service. His body mass index reduced by 6 kilograms per meter square over 10 months. So he went from severe obesity to a healthy weight range. There was a weight loss of 3.56 kilograms. John's story highlights raising the issue in multiple settings, connecting this to current health concerns, and providing general guidance can change a child's growth trajectory dramatically in a very short time. This is possible even in the context of childhood trauma and developmental disability. It also highlights that small changes in lifestyle behavior can make big differences. So watch out for GHK Bites newspaper, where we share more stories about the effect of routine screening and raising the issue of weight with children and their families. Thank you.
Thank you, Slavika. It's a very interesting presentation. So before we go to the next one, I just want to remind for you who would like to ask questions for the recorded presentations, please, you'll stay able to type that in and we will relay that to the presenters. So next up is Leanne Lombardo, and she'll be talking about stroke. Over to you, Leanne.
Morning, everyone. My name's Leanne. As a nurse who's worked in critical care, I found that oral health care was often a deprioritised nursing intervention, which would lead to poor health outcomes. And it was this personal interest of mine which brought me to my affiliation with COHORT. I currently work as a cardiac research CNC in the Nepean Blue Mountains Local Health District, and I'm also a very new PhD student with Professor Rajesh George as my primary supervisor. In my PhD study, I will be co-designing and implementing an integrated oral health care intervention and evaluating its impact on improving nurses' oral health care practices after stroke. Next slide. Stroke is a major global health burden, and in Australia, it accounts for 5.3% of deaths, 40,000 acute hospitalisations, and costs the health system about $633 million per annum. Recovery can be prolonged, and post-stroke patients face challenges such as neurological dysfunction and speech disorders. Routine activities of daily living, such as oral hygiene, is hindered by limited motor function and cognitive deficits, causing discomfort and complications such as hospital-acquired pneumonia, and patients are often dependent on nurses for their oral healthcare needs. While multidisciplinary stroke units are evidence to optimise outcomes for patients, and oral health care provision can play a role in this, research shows that oral health screening, procedures and documentation is often poorly done by health professionals. While stroke patients reported variability in the oral health care that they receive from nurses. Due to this, there is a compelling need to design and evaluate the effectiveness of an integrated intervention on stroke nurses' oral health care knowledge and practice. Our study design will be implemented in 3 phases, engaging stakeholders, including patients and their caregivers, clinicians and health experts in both the oral health and stroke field. In phase 1, which has already commenced, a literature review is being undertaken, and I'll give you a summary of this in my next slide. Once this is completed, I will proceed to phase 2, where I'll develop an integrated oral healthcare intervention using co-design methodology. This process will incorporate the oral healthcare needs and experiences of our stakeholders in stroke and oral healthcare, and also will be informed by the evidence that's found in phase 1. In the final phase of my study, I'll implement and evaluate the co-designed integrated oral health care intervention targeted at stroke nurses across a number of local health districts in New South Wales Health. We'll evaluate the effectiveness of this intervention on nursing's knowledge and practice of oral health care. In addition, I will assess the nurse's experience, acceptability and feasibility engaging in this education intervention. I'm currently reviewing the literature or phase 1 of my study. A scoping review is already underway, exploring the characteristics and effectiveness of existing oral healthcare education and training interventions for stroke care nurses. And so far, what we have found is there is limited research of interventions which improve oral healthcare practice in stroke. Often, education is the centerpiece of this multifaceted interventions, supported by guidelines and oral healthcare products. And there is reported variability in its effectiveness in improving nursing knowledge and practice in the stroke sphere. What we have found so far suggests and reinforces the need for research work, which I'm currently undertaking in my PhD. The current evidence shows that there is a gap in a sustainable and effective intervention to improve oral healthcare practice amongst stroke nurses, and prioritisation of interventional studies is needed to evaluate whether a co-designed integrated intervention is effective in improving the stroke nurses' knowledge and practice in oral healthcare. Thank you.
Thanks very much, Leanne. And we'll go next to Cynthia Valderrama. She'll talk about school dental assessment program. And this is a recorded session as well.
Okay, I'm Cynthia Valderrama, Senior Oral Health Therapist, Fairfield Oral Health Clinic. I'm presenting the School Dental Assessment Program, or we call it DISA. The background of the program, dental decay is a widespread problem for children in New South Wales. 40% of children aged 5 to 6 years have untreated dental disease, and this is significantly higher among children from a non-English speaking background. Compounding the situation is the lack of oral health awareness, knowledge of public oral health services, and language barrier. The high prevalence of dental decay can negatively impact various aspects of child's functioning, such as eating, speaking, and growth. To address this issue, partnerships were formed between Fairfield Oral Health representatives and principals from primary school within southwestern Sydney. This led to the introduction of the DISA program into 2 schools, providing oral health assessment to 74% of children on site and a subsequent treatment in oral health service. The aim of the program is to increase awareness on public oral health services and to improve access and care to primary school children, targeting the migrants, new migrants, refugees, culturally and linguistically diverse community or COG. Planning and implementation of the program. Partnership was formed to improve the oral health of children from COG groups. So Fairfield Oral Health staff and the principals from Sacred Heart and Smithfield West Primary School developed a program. This is to promote oral health of primary school children. The aim was to increase knowledge in identifying risk factors in developing dental decay by delivering a dental risk assessment and fluoride application at the school and providing a referral pathway to access the Southwestern Sydney Local Health District oral health services. This is one of the pictures wherein the setup at the school. So these are the instruments, setup of equipment, and then oral health talk, and then dental assessment to the children. The outcomes. The program was implemented across Sacred Heart Primary and Smithfield West Primary, involving 300 children. Oral health promotion was provided to all children, and risk assessment and fluoride application was carried out. 222 children, resulting in 177 requiring dental treatment. This is a graph showing the DSAP results, Sacred Heart and Smithfield West Primary School. So if you can see the blue color, which is children were assessed. So there's more than 40 children that was assessed as Sacred Heart, and in primary Smithfield West Primary School on the blue color, so it's more than 100 on the has been assessed. So the follow-up after completion of the dental assessment, parents of 44 children from Sacred Heart were contacted by telephone and offered an appointment. Of this, more than 2/3 attended their dental appointment. The Smithfield West was organizing the appointment at the time, so there is no data available. As a result of the DSAP program, patient flow to Fairfield Dental Service has improved, resulting in increased productivity. Again, this is just a graph showing uptake of dental service. So this is Sacred Heart Primary School. Child offered an appointment on the blue color, which is more than 40 children was assessed or given an appointment after the assessment. So the evaluation, 10 parents completed the evaluation survey, and they were all satisfied with the wait time for their child's appointment. And they rated the quality of dental treatment and experience as very good to excellent. So there was a question there again on the graph, how satisfied are you with the length of time you had to wait for your child's dental appointment? So on the blue color, again, there is satisfied. Okay, the feedback, the principal's statements are, this is a great program and one which should be continued. I would use the program again and would recommend it to others. The other statement, the service provided to the school gave the students a non-threatening, positive experience of the dentist, which for some was their first ever dental check. Quality awards in 2018. The DSAP program received the award of highly commended, acknowledging excellence in health. Where do we go from here? Implementation of the DSAP program in other child oral health clinics, partnership to be established with all primary school in Southwestern Sydney Local Health District, including the disadvantaged and special needs schools, forming a referral pathway using the multidisciplinary approach. Rollout of the DISA program and the start of the mobile dental service. Oral health therapists and dental therapists are currently providing dental assessment, dental treatment, and routine growth screening in a non-clinical environment or mobile dental van. These are the following references and also acknowledgement to all the staff that help us in this project. Thank you.
Thank you, Cynthia. And once again, feel free to type in your questions in the Q&A function. So up next to our next presenter, Eileen Neri, and she will be presenting Steps to Smile program.
Good afternoon. My name is Eileen Neri, Senior Dental Therapist for Southwestern Sydney Local Health District. I am the Substitute Investigator for Steps to Smile program. Introduction. Early childhood caries is a serious dental condition occurring during preschool years of a child's life when developing primary teeth are especially vulnerable. Dental caries, if not prevented from spreading, could lead to treatment that may require hospitalization and dental treatment under general anesthesia. For families who are not healthcare card holders, the treatment can be very costly having GA in a private practice. Background history. Steps to Smile is a new way of treating dental disease in children that aims to stop, treat, reverse, and prevent tooth decay and disease. It is successful in reducing dental treatment under GA in young children with dental disease. This program uses a method called risk assessment to guide oral health clinicians in the best way to help parents and their child manage the tooth decay and dental disease process. It is successful in reducing new decay, pain, and need for dental treatment under general anesthesia. Steps to Smile is a research project led by Sydney Dental Hospital in collaboration with other health districts, Western New South Wales, Northern New South Wales, and Southwestern Sydney Local Health District. Go Live program started in 2019, and a total of 228 children were recruited from the program. 76 came from SDH, 38 from Western New South Wales, 38 from Northern New South Wales, and 76 from Southwestern Sydney. Concern form, quality of life assessment form, parent-guardian questionnaires were obtained. I will be presenting to you Ms. C. She was one of the children that were recruited for the Steps to Smile program. She was actually listed on a GA waiting list before attending the program. Initially, her age of enrollment is 3 years and 1 month. Duration of participation to the program is 6 months. Initial examination, baseline findings, that she has pain sometimes on lower molars and upper molar. Existing demineralization, yes. Visible plaque, yes. Oral hygiene is poor. First visit baseline findings. Risk factor, high risk, high intake of flavored milk, juice, high intake of lollies, cookies, chocolates, and cakes. Protective factors, drinks water daily, brushes once a day with the help of mom. Self-management goal set by brushing teeth twice a day and lessen sugar intake. Subsequent visit findings, changes in risk factors achieved, less sugar intake, changes in protective factors achieved, brushes twice daily and drinking more water. Self-management goal achieved. Changes in clinical information, no pain, no new cavitation, no new demineralization. New remineralization on buccal surfaces of upper decent east and upper anteriors were evident. Outcome. The knowledge imparted to both parents and child have a positive outcome, putting patients' caries risk status from high risk to medium risk. Patient is pain-free. Both parents and patient can sleep well now. Patient is out of GA waiting list, and the value of good oral hygiene, having nutritious foods, and drinking water was instilled to both parents and child. Parents will bring back the child for a regular dental checkup. Silver fluoride treatment is cost-effective and atraumatic treatment work well, in combination with modifying the risk factors in caries progression. When doing a filling isn't enough, implementation of a novel evidence-based chronic disease management program, Steps to Smile. Thank you. I would like to acknowledge the team members of the Southwestern Sydney Local Health District's Steps to Smile program. Thank you.
Thanks very much, Eileen. That's a fantastic presentation. Now, the last but not the least presentation from Dr. Kelly Garmer, Dr. Sama Tamnafili, and Jeanette Savraj, and they'll be presenting about Aboriginal Oral Health Clinic.
Hello, my name's Kelly Garmer. I'm an Aboriginal dental assistant for Barrel and Tamor. I'd like to talk to you today about our Aboriginal Oral Health project that we run with Dr. Suma Thumanapelli and a Aboriginal dental assistant, Jeanette Stavrak. I've worked with the service for 16 years. I have been lucky enough to be involved with the Aboriginal project since it launched in May 2018. The Aboriginal project came about because of an identified need for Indigenous people to access dental services. In conjunction with SWSLHD Aboriginal Health, SWSLHD Oral Health Services launched Wingecarribee and Wallandilly Aboriginal Oral Health Project in May 2018. Clinics are held once a month at Barrel and Tamor Oral Health Clinics. We work closely with local Aboriginal agencies to introduce them to our project. The Aboriginal community welcomed the concept of having their own Aboriginal clinic, which includes ease of access and culturally aware staff. There are 3 goals of the New South Wales Aboriginal Oral Health Plan. 1, improve the oral health of the New South Wales Aboriginal population through primary prevention. 2, improve access to oral health services for Aboriginal people in New South Wales. And 3, reduce disparities in the oral health status of Aboriginal people in New South Wales. As part of this quality improvement project, we aim to improve awareness of public oral health services and improve access to Aboriginal communities by attending events such as NAIDOC Week to directly offer appointments to NAIDOC families. I'll pass you over to Suma.
My name is Suma Thumanapelli. I'm Senior Dental Officer for Barrel and Tamor Clinics, and I have been with Southwest for the last 8 years. I have been involved with the Aboriginal Oral Health program since its conception. Although I have been involved in many satisfying clinical outcomes, 2 cases come to my mind. As part of Aboriginal Oral Health team, I have been able to design and complete many comprehensive treatment plans in collaboration with our Aboriginal patients and carers. I have facilitated an immediate denture for a young Indigenous lady. Initially, the patient was embarrassed and nervous. On completion of treatment, I was happy to hear that the young lady was confident enough to pursue returning to workforce. I have also utilized the interagency referral system for one of my patients, referring them to mental health services. In this case, taking a holistic approach, I believe the Aboriginal Oral Health Project has helped identify and address her suicidal tendency, and the feedback from those patients was extremely positive and grateful for intervention. I'll pass it on to Jeanette.
Hello, I'm Jeanette. I'm an Indigenous dental assistant at Tamor and Barrel. I was fortunate enough to have a yarn with respected elder, Robin Young. Robin is the Aboriginal mental health worker for Wingecarribee and Wallandilly areas. Auntie Robin told me a story about one of her clients, an Indigenous gentleman. The man was unable to eat, unable to sleep, unable to have hot or cold food, suffered weight loss, was sweating in fear, had unresolved pain and a high level of anxiety. This gentleman did not have any serious health issues, he simply had a bad tooth. Auntie Robin explained Because of his upbringing from the Stalin generation, the fear of authority and government organisations had deterred her client from seeking dental intervention. This fear is generational in the Indigenous community, passed down from great-grandparents to grandparents to parents to children. Auntie Robin also explained that the Aboriginal Oral Health Program gives her clients a sense of control and safety. They feel comfortable that the program includes Indigenous staff that live locally. With the feeling of safety comes a willingness to seek further treatment. Behind every Aboriginal patient, there is a mob. The courier grapevine is a lot faster than the telephone. News of satisfaction or dissatisfaction travels fast. Auntie Robin went on to say that her clients that have visited the Aboriginal Oral Health Program had experienced improvement in self-esteem, which in turn improved their lifestyle. I personally think that our oral health service is like a flame. The mob can run from the flame from fear of being burnt, or in the case of the Aboriginal Oral Health Program, be drawn towards the flame, which offers warmth and safety of a campfire. If anyone would like further information about the Aboriginal Oral Health Program or how to refer patients to our program, please see the attached flyer, which will have a phone number and an email address. Thank you.
Thanks very much, team, for that wonderful presentation. So we've finished all the presentations and it's time for questions and answers. So I would like to thank all the presenters who are here for this session. It's great to see the work that has been undertaken clinically, but also at the same time very embedded in the community. So I guess that's really great initiatives and great research out there. I'm mindful of time, but I have a question for Leanne. Leanne, Leanne's there. Hi, Leanne. So
Hi.
just a question about your research. I mean, it's great to see and how like nurses and clinicians are like being involved in oral health or oral care for stroke patients. And stroke is one of those really type of conditions that has a significantly evolving kind of care provided to these patients. In your research, maybe in the co-design or maybe towards the implementation, are you looking into a specific stage of stroke transition, or like in the continuum of stroke as a condition, like it can be an acute or towards the rehabilitative kind of stage, or are you just going to find out which stage do you think would be the most suited based on your co-design? I just wonder about that.
So I'm 8 weeks into my PhD study, but we are looking at the acute setting post-stroke. So hoping that, we'll start there, and if we can get something that's quite sustainable and it can be a model of care, that we can actually then transfer that into other areas such as rehab and, across specialties as well.
Perfect. Thanks for that, Leanne. And I can't see any questions from the Q&A. So I guess that's all. And if you've got any questions for the presenters, please feel free to do that, and then we'll relay that to them. Thank you. Over to you, Ajesh.
Thank you, Jet, and thank you to all the presenters. A special thanks to the clinicians. We had to chase them up during their lunch and their tea breaks to do those recordings. As you can imagine, for many clinicians, presenting at a conference can be very daunting. So I think the recording was a nice way of capturing their input in various QI projects. Our last session now will be chaired by Associate Professor Bronwyn Everett, who's an Associate Professor in the School of Nursing and Midwifery at WSU. Over to you, Bronwyn.
Great. Thank you, Ajesh. And it's been great to be in the session today. And it's so good to get such an overview of the work happening in this space. But so I'm chairing the session on research impact. But before I start, I'd like to acknowledge that I'm on the lands of the Burramadical clan. There are people, the clan of the Darug, and who first settled the upper reaches of the Parramatta River, and they've occupied these lands for over 60,000 years. So research impact, or the effect of research after it's been adopted, is a really important focus now for research. So it's not simply enough just to publish research articles and leave it at that. We need to see how it actually is implemented and how that's sustained. So we have two presentations this afternoon. The first presentation would be by Professor Ajesh George and Dr. Bradley Christian. So thank you, Ajesh.
Thank you, Bronwyn. Now, Bradley can't present today, so I'll be presenting some of his slides. But yes, I think what I'd like to share with you is the journey we've been following for the last, I think, 10 plus years around developing this new model of care around oral health and pregnancy. I think a lot of the staff in the service and quite a few students have grown with this project. It started as a very small project in 2008 in Campbelltown Hospital in the antenatal ward, and has grown across the country and internationally, and you'll hear about that in my presentation. I think what is also very nice about this project is we really involved a lot of clinicians and staff in the oral health service at different stages of this project, and I think they've also grown to, I guess, acknowledge the importance of it. And Erin would have spoken a bit about, the interventions they've done in the US in this space. I guess today is more about what we did in the Australian context. So next slide, please. So firstly, just a bit of background, and again, this is what Erin highlighted, but we know, during pregnancy, due to hormonal variations, dietary changes, and increased nausea, pregnant women are more prone to poorer health, both gum disease and dental decay. We also know that poor maternal oral health is linked to adverse pregnancy outcomes and can increase the risk of their children developing early dental decay. As we've heard earlier, is actually the most common chronic childhood disease worldwide. We also know from interventions that improving the oral health of women during pregnancy can actually have a flow-on effect and reduce the dental caries in children. However, at this point, we don't really know the effectiveness of periodontal treatment in improving those outcomes. That has still not been confirmed. There's a lot of conflicting evidence there. Next slide, please. Oops, one slide go back, sorry. So based on all that, there's been a few guidelines since 2011 in Australia and internationally, really highlighting the need for all women to consult a dentist during pregnancy, and for them to really get a checkup. And we know that dental treatment is safe during pregnancy. Another key recommendation is for antenatal care providers to play a key role in promoting oral health by providing education, assessments, and referrals. Next slide, please. However, there are barriers in this space. For pregnant women, we know from the work we've done in southwestern Sydney and across the country, less than a third of women actually see a dentist, even if they have a problem. And the key barriers have been cost, which again is not surprising, but also lack of awareness about the importance of oral health and misconceptions, like you lose a tooth for every child. That's a normal misconception, and it's okay for you to have poor oral health during pregnancy. Another key issue has been only 10% of women were actually receiving any sort of information about oral health from the antenatal care providers. And when we drilled down, we actually found that women who were provided information about oral health during pregnancy were 3 times more likely to have seen a dentist. And if they had priority access, around 2.5 times. You can see how the information is a stronger predictor than actually having referral pathways. Next slide. The other barrier was from the other side, from the healthcare providers. And when we did a statewide survey in New South Wales with midwives, general practitioners, and obstetricians, we found that very few were discussing oral health or advising women to seek dental care. The key barriers for them were no clear practice guidelines, insufficient knowledge training, the cost of dental care, and also time constraints. And again, when we drilled down, we found that those who had formal training, more information, more years of experience were more likely to discuss oral health with pregnant women. Next slide. So taking all this into account, we wanted to develop, implement, and evaluate a new interdisciplinary model of care where we would capacity build healthcare providers to promote oral health, screening and referrals, but also to complement that, develop oral health promotional resources, training programs, and screening tools to help them in this role. Next slide. So we started it in, I guess, 2009-10 to develop the midwifery-initiated oral health program, or MIO, where we would incorporate oral health guidelines into the midwifery practice, so that at the first antenatal visit, pregnant women would receive from midwives oral health education, a basic screening, and referral to appropriate services. Next slide. So really, to develop this model, we spent a lot of time consulting with the consumers and the clinicians, really to try and find out how we could co-design this model of care. Really finding out from pregnant women, would you be happy with midwives suddenly discussing oral health? Because remember, this was something new at that time. And from the midwife's point of view, would they be okay in discussing oral health, and what are the gaps in terms of delivering this model of care? Next slide. So one of the first things we had to do was develop evidence-based resources. So at that time, this was 2009-10, there were no resources in the Ministry of Health around oral health and pregnancy. So we worked with a lot of consumers and stakeholders to develop the resource. We then translated it into 4 languages, particularly for Southwestern Sydney. We also developed a resource for the Aboriginal community. In addition, with funding from the ministry, we also developed a DVD that could be played in the antenatal waiting rooms. Next slide. The next thing we had to do was develop a training program. So we worked with a whole bunch of experts in the Australian College of Midwives to develop a 16 CPD point training program. We evaluated across 2 states, both New South Wales and Victoria, and we found that at that point, the program was significantly increasing their oral health knowledge, next slide, as well as their overall confidence to promote oral health. Those are a few of the quotes from, at the bottom left is the first cohort of midwives in Southwestern Sydney at Campbelltown Hospital that did the training. And then the other one is actually a first cohort of midwives in Victoria. That was 2011. And these are some of the quotes from them. Next slide, please. We also knew that really to change perceptions of midwives in this space, we had to address it from a grassroots level. So we worked with academics at Western Sydney University to implement an oral health module into the undergraduate midwifery curriculum in 2015, and we evaluated its impact on the knowledge and confidence of students across 3 years. And again, we were happy to see that it significantly improved both these outcomes, both knowledge and confidence, and it was sustained just even at the end when they were leaving and becoming new graduates. And again, these are some of the quotes from the students, the first cohort of students from the university. Next slide. The other thing we had to do is we wanted to develop a very simple screening tool, because midwives, like all the other presentations you heard, all the other professionals, don't have a lot of time to spend on this. So we developed a very simple 2-item screening tool with an option of doing a visual screening of the oral cavity. We evaluated and we found it had high sensitivity to identify women at risk for poor oral health and needing a referral. Next slide. At the end, we also had to test this model. And so we were fortunate to receive funding from the NHMRC, and we did a multi-center trial across 3 hospitals, Fairfield, Campbelltown, and Nepean. We recruited 639 women, and we followed up 479. And we had multiple teams, and these are the dental staff that were trained to deliver the dental intervention. Next slide. So really what we were doing for this trial is we had 3 groups of women, 3 arms. The first arm was the control group, where the women were just provided a brochure. The second arm, the women received an intervention from the midwives, where they were given oral health education, a risk assessment, but the referral was to existing dental services. And the last one was where the midwives did the intervention, but we provided a priority referral pathway for the pregnant women. Now, the reason we did this is because we know from international evidence, particularly in the UK, where all pregnant women have free access to dental care, even in that situation, only around 50 to 60% of women see a dentist. So we don't believe that just providing a referral pathway will address these challenges. So we wanted to see which of these, whether it's just raising awareness or a combination, would have an impact. And so what we found was the last arm, combining the awareness building and a referral pathway, had the biggest impact on the improvement in uptake of dental services. There was more than 50% improvement. The oral health knowledge and the oral health status in terms of the reduction in bleeding, plaque, and dental decay, and the quality of life. There was no impact on their birth outcomes. However, we followed up the children of these women that were part of the trial, and we collected data when the children were 3 to 4 years. There was a small improvement, but significant improvement in the maternal oral health knowledge between the control and intervention arms. But when we put them all together, the data together, we looked at overall, we found that the women that had better oral health knowledge, their children had less dental decay and they had less caries-causing bacteria in their mouth. So there was, again, we were seeing an impact of improving the oral health literacy of the women and the flow-on effect in terms of oral health outcomes. Next slide, please. We also did a process and economic evaluation, and we found that the program was acceptable and feasible to implement in the real world from the dental point of view and from the pregnant women's point of view and also from the midwife's point of view. And more recently, we did a cost-effectiveness analysis, and we found that just by raising awareness and not even improving the referral pathway, using current referral pathways, it is, in the short term, very cost-effective for health services, the intervention. So that was really very encouraging. Next slide, please. So really, what has been the impact? So first and foremost, the training program was endorsed nationally by the Australian College of Midwives, and so far 460 midwives across the country have done the training. Next slide. It has also increased community awareness. So the resources we developed were distributed statewide, and through the Ministry of Health, we know that more than 90,000 of these kits have been distributed to various antenatal and dental services. We were fortunate to also have our program featured in the Channel 10 News, which raised the profile of the program. And in 2015, the Minister of Health actually endorsed the DVD that we developed at Thorough Aboriginal Medical Services. Next slide. It has also resulted in midwifery practice change. So the program has been implemented across 59 maternity services in New South Wales and Victoria. That map, there is the various antenatal services in various regions of Victoria that have adopted. And those are some of the comments from the pregnant women and the Victorian team. Next slide, please. It's also improved patient outcomes. So on the right-hand column, that is the rollout of the program from 2011 to, still going on. But when the Victorian government looked at the number of women that were accessing dental services, there was a more than 50% increase. And those specific areas like Murrumbidgee Local Health District and Peninsula Health, they too had a significant improvement in the number of women accessing dental service, which has been really great. Next slide, please. We also had a key role in influencing policy. So the midwifery program was included in Victoria's Action Plan for Health Promotion, which started in 2011 and has just been renewed, and it's in the new plan as well. The Victorian government included our screening tool in their online obstetric system, and it's been used by 75% of hospitals in Victoria. The screening tool has also been promoted in Queensland Health and has been used internationally in a number of hospitals in the US, UK, and Jordan. Now, one of the things that we're very proud of, next slide please, is last year, the World Health Organization identified the MEO program as a best example of integrating oral health into primary health care. And they've actually included it as a case study in their upcoming guidelines. So we're quite proud that a study that started in Campbelltown Hospital in 2008 has reached the world stage. I'm going to end my presentation by just sharing some feedback from a few staff that have been involved in the journey, as well as midwives. Next slide, please. So,
hi, my name is Diana Wiskich. I'm a dental assistant with the South Western Sydney Oral Health Service. I also have an oral health certificate, which gave me the opportunity to get involved in research. I started being involved in research in 2009 and all the way up to basically 2019. Initially, I was recruited to the MEO project with pregnant women. That was based at Campbelltown Hospital's antenatal clinic, where I had the opportunity to recruit them for our project. And initially it was with questionnaires and data entry, and it followed on to our Mio Kids project, where I was able to contact these mothers and then follow through with their children, offering dental appointments through our various clinics in Southwest Sydney and also Nepean Hospital. I gained a lot of experience in research, and it further developed my passion in oral health, which was great. I also got to work with a lot of different professions, from midwives to research officers, different area health dental staff, as well as throughout the clinics in Southwest Sydney. So yeah, I found it very useful professionally and personally, because I've always been really a big follower of oral health and promoting that in the community, and so being involved in the research projects definitely helped me follow this on.
Hello everyone, I'm Veronica. I'm a dental assistant and has been working for Southwest Sydney Local Health District now for about 20 years, and been lucky enough to have been able to work on various projects over the years, research being one of them. When I got approached to ask if I was interested in working on the Mio project, of course I said yes. I'd heard a lot about Professor Rajesh George and his team and couldn't wait to meet him as well as work alongside him. The Mio project started at Campbelltown Hospital in 2009 in the antenatal clinic. Questionnaires were completed with our pregnant patients while they were waiting in the waiting room. We were also teaching them oral health promotion on how to look after their teeth as well. As the project grew, Camden and Nepean hospitals were included into the project. Also got to work at the clinics at the various sites in treating our pregnant patients, where again I got to teach them all about oral health and the tools that they needed to use to take home to teach themselves as well as their families on how to prevent tooth decay. Towards the later part of the project, babies were born, and at the age of around 2 to 3, I was lucky enough again to be able to catch up with the mums and help assist in their children in learning how to prevent tooth decay again at home. Have a big passion for oral health promotion. So given the opportunity to teach our local community on how to be dentally pain-free was one of the biggest satisfactions I got out of working on this project. Also very proud to be part of a project that got rolled out into various states around Australia and has now been recognised by the World Health Organisation. Thank you.
Next slide will be from midwives.
And asking the 2 questions like read the bleeding gums and do you have any problems with your teeth or any sore teeth, I had no problems with that. I thought that the actual thought of looking into people's mouths just made my stomach turn. But when it was directed, when we were told that we didn't actually have to do a full examination, just look where they had the sore tooth or sore gum or the bleeding, it was a lot easier, and it's quite easy to do in practice. Like I do it now, so no problems there.
I think some of the midwives had an aversion to looking in the women's teeth, but I think we got over that by saying it was more about reaffirming to the women that once they, like going to the doctor, if you've got a sore toe, you want them to look at the toe. And so looking in their mouth just reaffirms to the woman that, yeah, you care, and that you're confirming, yeah, there is redness, soreness, whatever there, and encouraging them to go and see a doctor to try and get, obviously, better dental care for them and eventually, obviously, their children. You have to do that education. The book itself, it gives you so much information and knowledge about dental care that you haven't done in any of your midwifery training or midwifery practice. So it is something new to a midwife because that's not what we were trained in. But it does, as Vicky said, gives you that information and knowledge that you need to be confident in talking to women about their dental kind of care. And it doesn't take a lot of time. It's not like a big assessment.
No.
It takes 2 minutes to kind of, I suppose, touch on something that could ultimately affect their baby's birth weight, their baby's, prematurity, and their child's teeth. So it's in an antenatal, I suppose, midwife whose role is to look at trying to get the best outcome in the pregnancy for her outcome, it's another factor that we can try and help with.
Thank you. So the last slide is just to acknowledge the team that's been there over the last 10 years, the funding bodies and all the stakeholders that have helped us along the way. So thank you.
Okay, thank you, Ajesh. That's an amazing presentation, and I think what a great example of from little things, big things grow. So, and that was so interesting for me to see in that last slide a midwife who I trained with 40 years ago. So the first time I've seen her in that long. So, okay, our next presentation is on Aboriginal and Torres Strait Islander health and pregnancy, and Ariana Kong, Renita Rutley and Tanya Dennis Ikenwim will do the presentation. Thank you.
Thank you, Bronwyn. Before I start, I would just wish to acknowledge and recognise that we're all meeting on Aboriginal and Torres Strait Islander land today. Here where I am meeting today, I'd like to acknowledge the Cabral clan of the Darug Nation for the traditional custodians of the land. I'd like also to pay my respects to elders both past and present, and to any Aboriginal and Torres Strait Islander person here today or overseas. Next slide. Yep. Before I start, I'd like to mention that this was my PhD project. So I'd like to acknowledge my supervisors, Professor Jess George, Associate Professor Lucy Ramjan, Dr. Mariana Souza, Associate Professor Michelle Dixon, and Joanne Golding. I'd also like to thank the Aboriginal health workers, the Aboriginal and Torres Strait Islander pregnant women, and also the Aboriginal graphic designer, Jasmine Sarah, who designed the art throughout using the presentation. I'd like to thank you all for joining me in developing this program. So in the community where I've worked on this project, many Aboriginal and Torres Strait Islander pregnant women are involved in a program where Aboriginal health workers provide antenatal support. Aboriginal health workers are often the bridge between Aboriginal families and health services. So when I spoke to the Aboriginal health workers, they identified that oral health was an area of need for their pregnant clients, which was important because poor health during pregnancy can impact the well-being of both the child and the mother, as discussed in Ajesh's presentation. I yarned with the Aboriginal health workers about how they could promote oral health and whether they were receptive in being involved in a project, in this project. While the MIO program was developed before this research, there was also a need to create something that better addressed the needs specifically for Aboriginal and Torres Strait Islander families. So the aim of my PhD project was to co-develop and pilot as a culturally safe antenatal oral health program that can out mums and bubs with Aboriginal and Torres Strait Islander communities. I use a participatory action research approach, which is quite similar to a co-design methodology, where it really focused on Aboriginal health workers being the experts and being the people to really drive the program and how it was developed. Next slide, please. So this is basically the process that we went through to develop the program. I was asked to first look at the literature and then also to conduct some focus groups with the Aboriginal health staff and also interviews with Aboriginal pregnant women. These two phases informed the third phase, which was really around developing the program. So at this stage, that's when we employed an Aboriginal graphic designer, and I facilitated a workshop with the Aboriginal health staff to further look at the details and brainstorm the details of these potential resources and really what they would need. I also employed an Aboriginal research assistant to help me undertake a process of extensive consultation, where and at the end of this development phase, we developed resources, a face-to-face training workshop, as well as a culturally safe priority referral pathway to the public dental service. Next slide, please. So to pilot test the program, I did some pre and post testing with some Aboriginal health workers. In one of the workshops, we found that all Aboriginal health workers found the resources in the program to be useful, relevant to practice and culturally appropriate. In our preliminary findings, we also found improvements in knowledge and confidence about oral health during pregnancy. So as you can see on the right here, the suite of resources we developed, and also a photo from our training workshop. Next slide, please. After we delivered the training, we went back and gathered some informal feedback on how and when the Aboriginal health workers were able to use some of the training and resources. So this is just, again, really informal feedback, but I thought I'd highlight some of these quotes from some of the Aboriginal health workers. So one quote was, I've spoken to about 17 mums, and this was within a month. The mini oral health assessment has prompted me to speak to my mums more in depth regarding the oral health, and especially their last checkup with the dentist. The information on the pamphlet is great, as I use pictures to talk through the information with the pregnant mums, young children, which has been excellent in engaging mums too in that conversation. So even through this training workshop, which was only a couple of hours long, it already started to change the Aboriginal health workers' practice. The second quote was with a different Aboriginal health worker, and she said, another mum stated that she hadn't had a checkup in over 3 years and put her own health on the back burner as life gets busy. She said the fact that I had discussed with her the importance of having one for her bub had made her prioritize her oral health more, and she booked in with her regular dentist. So it's just really amazing to see that, just through this process that we had undertaken and through the brief training program and the resources, it had really supported the Aboriginal health workers to change their practice and actually see changes among their clients. So I'd just like to mention also, in addition to these changes in practice, the Aboriginal and Child Family programs has decided to restructure their service. And they actually also decided to integrate this program and the resources and the training into their new restructure. We're also consulting with Dental Health Services Victoria, which is the main public health organisation in Victoria, as well as the Victorian Aboriginal Community Controlled Health Organisation, in adapting this program into their communities. We've also received interest from the Hunter New England Local Health District in adapting the training and the resources into their setting. So now, next slide please. I would like now to introduce Tanya, who is a senior Aboriginal health worker who participated in developing this program.
Hi, my name is Tanya. I'm a proud Gamilaroi Uwalari Yuri from Gamilaroi and Wawan lands, north and west New South Wales. So currently I am the Senior Aboriginal Health Worker for Aboriginal Child and Family Health Service across the Southwestern Sydney Local Health District. The University of Western Sydney approached the Aboriginal Child and Family Health Service to support a creation of a project involving the Aboriginal members of the community and oral health care. So the benefits I gained from this project was the education relating to the importance of oral health care and pregnancy for Aboriginal women across the Southwest Sydney Local Health District. Additional knowledge of the potential impacts of poor oral health during pregnancy for mum and bubs. This increased my health promotion practice to ensure our families are aware and referral pathways are in place.
Thank you, Ariana. It was a great presentation. So it's just been so exciting to see how research projects have been translated into practice and the impact that they're having. I guess I can't see any questions in the chat, so I do have a question, and I think that I might ask Ajesh a question first. And Ajesh, the MEO project commenced in 2009, and there was, I mean, I think that most people, a lot of people are probably familiar with the lag time it takes to get research translated into practice and for impact to occur. And I think that's it used to be around 17 years. So yours is substantially shorter. But if you had one tip, I guess, for people in the webinar today about the importance of impact, what would it be?
Yeah, I think in terms of impact, I think you got to really engage with your end users and the key people that will drive your project forward at the onset. Don't wait. Many people think that impact happens at the end of your project, not necessarily. I mean, if you look at the brochure that we dealt, that was in the second year of our project. And we were able to capture the impact in terms of raising awareness just by that one resource. So don't wait to deliver impact. Identify impact measures from the start, engage with consumers and stakeholders at the start to see who can support you in delivering those impacts.
Yeah, great. Thank you. I think that's great. That's a great tip, great advice. I might leave the questions there. I'm conscious that we've just slightly over time. We've got the next session to go. So thank you. Thank you, Ajesh.
Sure. Thank you, Bronwyn, for sharing that. All right. Thank you all for still staying on. We're almost finished. We've got our final presentation and we're going to try and speed it up. So really, this was just to share our experiences of involving consumers and stakeholders in the journey, and this particular journey, developing health promotional resources. And we're going to mix it up between myself, Tiffany, and Ariana. Next slide, please. So the importance of health promotional resources, well, and this is, most of you already know this, but sorry, go back. It helps convey key messages at a population level, can play a key role in improving the health literacy of the community, and particularly can help target those hard to reach population groups. But it's important that these resources are evidence-based, they're tailored to the needs of the consumers and supported by key stakeholders to help with the dissemination. Now, since 2008, we've been quite fortunate to have developed a number of resources in this space with the Ministry of Health and various stakeholders. So starting with pregnancy, going to the Aboriginal community, as well as, stroke, heart disease, diabetes, the most recent one, Tiffany's project around eating disorders and oral health. We've also translated them into various languages, and the last two are actually the international impact of that. So we've actually followed the same process with consumers in Tanzania. So that brochure is in Swahili. The Tanzanian government have endorsed that to promote oral health among their pregnant women. And the last one is around diabetes and oral health through Prakash's project that has been translated into Nepalese, and the Nepal government have endorsed. Next slide, please. Now, this is what we've been following, a systematic process in developing these resources. Now, it may be already what you are doing out there, but we just thought we'd share it. So I think one of the first things we always ensure is establishing a working party that is reflective of all the key stakeholders that are involved. Then really scoping the evidence, determining the content of the resource based on the evidence, refining the resource with experts, obtaining consumer feedback, and then finally getting endorsement and dissemination. So we're going to expand on each one of those sections. So next slide, please. So the first one is really establishing a working party. And just as I mentioned with Bronwyn's question, really identifying which organizations you want to involve at the start to endorse your resource. Don't wait till you finish the resource to go to the organization and say, we'd like to be endorsed. Approach them, get them to be part of your working party. And if they're too busy, well, keep them in the loop, give them feedback. So establishing that working party and ensuring that the adequate representativeness is very important. And also, it's always hard to engage with consumers. Sometimes you may have stakeholders that have already connections to consumers. So bringing them in is also important. In addition, really identifying whether you have existing resources for a graphic designer. For those of you who use the graphic designer, sometimes if you rely on a company to do it, very often when you go to get the feedback you need to really make those changes very quickly to get back to the stakeholders. So really need to ensure the graphic designer is on call and is able to make those changes very quickly. You may also need to look at resources for photographs and printing, and really setting up a regular meeting pattern with the working party. Over to you, Tiffany.
Thanks, Ajesh. So step 2 is to scope the evidence. And the first part that we start with is looking at what is the problem that we are trying to address. And from that, we develop the aim. So having a look at who do you want to target? What is your target audience? What do you want them to know about in the particular resource that you're developing? And then what are the sources and places for support that they can achieve this from? So then you look at your aims and you say, okay, we need to conduct a literature search to actually map out what is going on in this area. And this can often be quite a daunting process if you've never conducted a literature review before. So firstly, there are a couple of areas that you can look to for support. So either you can seek support from your hospital librarian and they can go through how you can conduct a literature search and look at the problem that you have and the research question that you have and help identify what databases and what key terms are going to be useful for you. Or you can obviously reach into your network and talk to some other clinicians or some people that you know and trust that have conducted literature search before that may be able to assist you. And so what you might be looking to find is things like peer-reviewed papers, clinical practice guidelines, consensus statements, and other policy recommendations or documents around the specific area that you are looking to develop a resource on and compile that evidence together. Next slide, please. So then next you've got to determine the content. So what is actually going to be in your brochure or your resource that you are then going to put forward that message through to your target audience. So it's important that your brochure then goes on to address your initial rationale or your aims. So again, the target audience that you're looking to put the brochure out to, what do you want them to know about? And then what are they actually going to do with that resource? So what is the end outcome? Are they going to be referred on to dental services? Are they going to call a number? What is the end of that? So your resource should typically aim to include an explanation of why your topic is important. So if you've got any statistics, so for instance, in our eating disorders and oral health brochure, it was saying that regardless of your eating disorder subtype, you are increased risk of dental caries and dental erosion, including relevant images, so making sure they're representative of the target population, a call to action. So this is where you can either put in your messages of you can contact a dental service and you put in your contact numbers or where they can seek support from and help professionals to contact, and any additional important information that you think that you want that target population to have complete access to. Next slide. Ariana, over to you.
Yeah. So step 4 is about refining the resource, and this is really with your working party and any other relevant stakeholders that you might have. At this stage, generally, we don't seek consultation with the consumer specifically because we leave that towards the end. But at this stage, we really want to look at refining aspects like the words that we use to ensure that it is appropriate, the image choice, making sure, as Tiffany said, that's representative of your target population. We also want to look at the color scheme to see if it represents what the, I guess, the particular condition or the issue that you want to look at, and the formatting, layout, and also the readability. Next slide, please. So I just want to talk a little bit more about readability. It's basically a score that tests how easy it is to read your resource. Readability tests are available online and they are free. So we just have a screenshot on the right, just as an example of how we've done it for our resources. This was an example from the eating disorder and oral health resource. A good score really depends on your target audience. I know for some communities, we aim for a grade 5 level, but in other communities, we aim for up to a grade 8. It really just depends on who your target audience is. Next slide, please. Oh, back. Yep. Then at this stage, then you want to have a look at obtaining consumer feedback. So how you will obtain consumer feedback really depends on how accessible they are. If you can contact them in person, face to face, that's probably best. So you can get them to look at the resource, the draft resource, and get them to provide feedback. For the eating disorders and oral health brochure, we contacted the Butterfly Foundation Lived Experience Collective. And so because that's national, we contacted consumers from across Australia. So we had an online survey and it looked similar to what we have on the right here. We asked consumers specific questions about the different sections of the resource, what they thought about the images, the words, and any other comments or feedback that they had. Next slide, please.
Yeah, so once you get all that, it's really about finalizing the brochure. So going back to the working party, incorporating the feedback, and then ensuring that you've got the relevant licenses for the images and compliance with various branding guidelines. For example, Ministry of Health changed their branding guidelines late last year, so we actually had to change the initial design of the eating disorder brochure. And lastly, because you've involved them from the start, it is much easier then to get seek endorsement from the stakeholder organizations. Very often they share it with their executive committee, or they have another formal process, and then you get the relevant logos. And then it's important to establish a dissemination strategy, and you should use the various stakeholders to assist you with that. That could be through printed material or through social media, newsletters, and clinicians. And even if you have it on one website, you can then promote that website through other stakeholder organizations. Next slide. So these are just some of the various organizations we've used over the years. And I think, because of that engagement, that methodology we followed, we've been able to get a lot of representation. We say New South Wales government, but there were a lot of LHDs involved as well. Now, I know this is relating to oral health promotional resource, but I think you can apply this methodology in any sort of health promotion resource you'd like to develop for your community. So that ends our last presentation. I think we're 1 minute over or 2 minutes over. So I'd like to thank everyone, all our presenters, our keynote speaker, Associate Professor Erin Hartnett, our chairs, as well as all the attendees. I hope you all have enjoyed the presentation. Now, today's symposium would not have been possible without the amazing teamwork and coordination from the COHORT team, particularly Ariana Kong and Tiffany Patterson-Norrie, as well as the support from the Research Directorate in the LHD and Ingham Institute. We still have a long way to go in the integrated oral health space, but we're very excited about the future. Last week, Western Sydney University, in collaboration with various partners, launched a virtual national center called the Australian Centre for Integration of Oral Health, or ACO, at the International Convention Centre, Sydney. The launch was supported by various key organizations, including the WHO, the International Association of Dental Research, New South Wales Health, and Dental Health Services Victoria. Now, the key focus of ACO is really to expand the integration of oral health, both nationally and internationally, through partnerships to avoid duplication and enhance research translation. So we really look forward to working closely with South Western Sydney LHD in this new initiative. So on that note, thank you very much.